first about the superficial aspect of the neck, and then go a little bit deeper into the deep aspect of the neck. Some of these structures we've had a little bit of an opportunity to see because we saw, for example, the platysma muscle hanging over the edge of the mandible and coming down in the anterolateral aspect of the neck. Okay, so it's not just an attachment between the head and the trunk and a mechanism to support the skull, but it also is this conduit for nerves and vasculature that interconnect vital organs in the body. You'll find as you start to take some of your pathology courses that there are actually certain things that manifest themselves in the head and neck area that are maybe all the way down in areas of the pelvic cavity or the lower abdominal cavity that can be manifested in regions of the head and neck. So I'm just going to show you this slide. This is something we're going to look at in greater detail. We've talked about fascias before. If you remember, we have basically two types of fascia that we find throughout the body. One of those types of fascia is the subcutaneous layer or the superficial fascia. And one of the unique things about it is it contains fat. Okay? Running through that fat are a lot of structures, some superficial venous channels, also some superficial nerves and so forth. And then underneath this is there's this deep fascia, and this deep fascia is a little less in relationship to fat content. It has little or no fat, but it is there to wrap around these deeper structures, muscles, nerves, blood vessels, in order to hold them together. That's really what its role is. So we'll look at fascia again when we get near, probably into April, we're talking about pathways of infection, because fascia plays a significant role in is both a limiting factor and a factor associated with that. Do you have a question?
So is the canthor and scarpus fascia only in the abdominal region?
That's the only place they use that terminology.
Okay.
But it's still superficial fascia, and because when we go up in the thorax, if you remember in the thorax, underneath the skin, there was a fat layer that was covering, for example, pectoralis major muscles and so forth. And remember, the one thing that I mentioned to you in regards to the head is that muscles of facial expression are essentially the only skeletal muscle group in the body that are actually held together by superficial fascia. Okay, so not just covered by it, but they're also held together by superficial fascia. All other skeletal muscle layers in the body are held together by deep fascias. Okay, so we've got some superficial nerves that are arranged in what we call the cervical plexus, cervical referring to the neck. And there is a superficial portion which is primarily sensory. I say primarily sensory because you have to realize that the nerves that are coming and going from the neck, or any other place in the body, the face as well, that these nerves are more complex than just straight sensory input. They have motor output, and a lot of that motor output has to do with the way the autonomic nervous system interconnects, for example, with sweat glands or sebaceous glands, or even some of the vascular bed associated with some small arterioles going through the skin. So it's much more complex than just a sensory entity, but it is usually looked upon as being primarily sensory. So there are branches of cervical spinal nerves that make up this plexus, anywhere from C2 down to C4. Actually, you can probably throw C1 in here as well. But this enters the spinal cord at a specific region referred to as Erb's point. This was described by Erb. He was actually a head and neck surgeon of his time. And these are nerves that we took a look at. We'll look at the images again. Lesser occipital nerve, greater auricular nerve, transverse cervical nerve, and supraclavicular nerves. These are innervating skin from a sensory perspective. They are actually coming out on the outside of the platysma muscle to do this, and they are coming from their spinal rami or roots, and these are anywhere from C2 down to C4. There's a deep portion of this plexus, though, that is pretty much motor. okay? Once again, when I say primarily motor, when we're talking about innervating muscles, whether we're talking about innervating skeletal muscles or we're talking about innervating smooth muscles, we're talking about entities that are also sending information back to the central nervous system, so the central nervous system knows what these organs are doing and can react to whatever sensations somewhat in position of that the muscles are moving the bone or moving tissue to anything like whether or not the glands are in that area are secreting properly. Okay. So these are branches at a little bit higher up, C1 to C4, which innervate the geniohyoid muscle and some of the other infrahyoid muscles. Okay. So we'll look at that as we go along. It's kind of interesting. C1 actually helps to contribute to this this superficial portion, but it's usually designated as more of a deep cervical plexus nerve than not. Okay. So here's this cervical plexus in this image out of Anatomy in the Human Body by R.D. Lockhart. I know this textbook isn't published. It was probably, at the time it was published, your parents weren't even born. But from that same standpoint, it does have some really nice images and descriptions of, in particular, nerves throughout the body, including the head and neck. And it labels them rather succinctly, but also very accurately. So it is a good text to go through. I mean, you can find it in the Health Science Library, or if you want to buy the book online, it probably costs about $2 now, but it'll cost you $15 to ship it. So these are nerves associated with the cervical plexus. So this is showing you the cervical plexus. Now it's interesting, when we talk about a nerve plexus in the body, if you remember when we first started talking about spinal nerves, they have arms that go either to the back of the body wall or to the front of the body wall. And those are called rami of the spinal nerve, okay? And there is a posterior rami that goes to structures more in the back. Very short because the spinal nerves are coming out of openings called spinal foramen that are in between vertebrae. Okay? However, there are longer extensions of this spinal nerve called anterior rami. And these anterior rami are going to anterior regions of the trunk. We talked about a little bit about that in relationship to the abdominal wall, but they are also going into form these plexuses associated with three regions of the body: the neck, the upper extremity, and the lower extremity. Okay. So we're going to see here we have the cervical plexus, which is anterior rami of spinal nerves, anywhere from C1 actually down to C8, and we see them here coming out. This is the cervical plexus. This area right here is what we refer to as Erb's point. So this area is Erb's point, and Erb's point is right along the posterior border of the sternocleidomastoid muscle. Okay, we've had an opportunity to see that a little bit in the head and neck. We had an opportunity to see it as it came down to the clavicle and on the top of the thorax, clavicle over here. Here's the trapezius muscle over here. Here's the sternocleidomastoid muscle. Platysma muscle has been removed. okay? This would be deep to these nerves, okay? So this is Herb's point. So theoretically, you know, Herb was a clinician. So he was looking at, you know, where could we find this point? Well, it's about the top of the thyroid cartilage part of the airway, and come down from the angle of the mandible down there. If you injected there just a local anesthetic, you would numb the entire skin, coming all the way up behind the ear, including the lower portion of the earlobe, behind the ear, underneath the mandible, and down into the region of the shoulder. Here, these supraclavicular branches here, and this little transverse cervical nerve coming here. You would be able to use that injection site with a local anesthetic to anesthetize that entire region. Yes, Brian?
So is this skin or muscle or both?
At this point, it's just skin.
Okay.
Okay, we have to go a little bit deeper and a little bit more medial to anesthetize structures and muscles. So, for example, the surgeon to make his incision, to go in here, maybe to do a lymph node dissection or something like that, this would be a point he would have to understand to do that, as opposed to, for example, maybe also what we would call an intended local, where there was a sedation given along with a local anesthesia. Actually, oral maxillofacial surgeons, that's what they do. They do an intended local. They use a sedation to get you asleep, but then they use a local anesthetic, so there is less chance that you're going to feel any pain during the procedure. Do you have a question?
Is Herb's point just where the superficial nerves enter the spinal cord, or superficial?
Yes, just where the superficial portion of the cervical plexus.
Okay. Do you see that on our cadavers, or
Oh, yeah.
it's too deep, or it's too superficial?
No, we'll see it on a cadaver. I'll actually show you some images of the cadaver. Actually, we'll be dissecting that this week. I'll be in the lab this weekend on Saturday, doing that dissection, probably Thursday, getting started. So, for example, here we have a nerve that is coming up to the earlobe and also to the angle of the mandible. This is the great auricular. And that's important for us because that is actually branches of C2 and C3 that are not only innervating the lower portion of the earlobe, but they're also innervating skin that is over the angle of the mandible. Where else did we talk about in the past a cervical spinal entity associated with C3? Is there another nerve that we talked about specifically that was associated with C3? Phrenic nerve, okay? So there's potential here if there's something going on in the thorax, because the phrenic nerve has one of its rami associated with the diaphragmatic pleura or the pericardial sac. There's a potential that something going on down in the thorax in relationship to some type of atypical sensation, which we call paresthesia, that will be manifested at the angle of the mandible. Okay, so what teeth are closer to the angle of the mandible? Third, second, first molar, okay? What about in relationship to a joint that's close to that area by the ear? What's that joint called? Temporomandibular joint, right? So you've got, I'll tell you this, diagnosis comes before treatment. If you don't know what you're treating, you're making a big mistake for going in there and doing anything, all right? So if you wind up with a patient, let's say, that has bilateral pain in the angle of the mandible, what do you think's the first thing you should do?
Palpate, I guess, start there.
Okay, or you can take a quick look in their mouth and see if you see anything that's obvious dental, and if you don't, just dial 911 because they may be having a myocardial infarction. Okay, it's unusual to have bilateral pain simultaneously, in particular in relationship to the jaw. All right, so we've got that, and then coming back here, we've got the lesser occipital nerve, and then coming down across in this area here, we've got the transverse cervical nerve, and then these bundles of fibers coming down here over your shoulder, over the top of your shoulder, the top of your arm. These are referred to as supraclavicular nerves. Okay, so these are 4 branches that are coming anywhere as high as C2, as low as C4. Okay. If we look at the chart here, this is in Eric Baker's book, but this is a TEMA book, and the primary TEMA atlas that all of the authors that do anything else that they need an anatomical image comes out of this book, and Gilroy's Atlas of Anatomy. So all of the images can be found in there. We have some copies of that in the lab, okay? But I don't know if it's on your reading list. It should be if it wasn't. But the smaller edition of this associated with the head and neck is Eric Baker's Head and Neck Anatomy for Dentistry or Dental Medicine. Okay. So this is the chart that he used. Now these are posterior rami. Okay, so we're not talking about posterior rami now. We're talking about anterior rami. We'll talk about these this afternoon as well. But we have these sensory branches. C1 is not typically listed as a sensory branch, but I'll be very honest with you, in where it comes into muscles in the back of the neck, it actually has the sensory branch, or sensory component. So we have C2, lesser occipital, great auricular, okay, both have C2 components. C3, we start to pick up transverse cervical nerve in here as far as sensory branches. And then C3 and C4 with these supraclavicular nerves, okay? So they form the sensory portion of the cervical plexus. They're receiving sensation from your skin in these regions of the neck, regions of skin covering the mandible, regions of skin covering the lower portion of the auricle or the ear, okay? We'll talk about the motor aspect of it in a minute, but that forms an interesting nerve loop called an ansa, or ansa cervicalis. Okay, so these over here are the sensory components that are coming from the surface skin. Brian, you asked if you can see these in the lab. Okay, here's kind of a superficial dissection. Here's a platysma muscle coming down here. Okay, here is a Erb's point right here. It's kind of covering up this muscle coming down here underneath it, called the sternocleidomastoid muscle. Here we see a nerve coming across the neck. This is a transverse cervical. I'll label that in a minute. Here is a great auricular, and then coming back here is one of the distributions of the supraclavicular. So this area in here, okay, here's platysma. And coming out under here, this area here, this is Erb's point. Here is, here's a great auricular. Here actually, this is a lesser occipital. This twig coming across here is a transverse cervical. Here, and we see a little bit of, over here, see a little bit of one of the posterior portions of the supraclavicular. here's this McMinn image, yes, Frank?
So just make sure I can sort of orient myself, the branches of the facial nerve, 7, you've gotta go a little deeper. You'd have to start taking off muscles to see them, or they're on the same level.
And higher, much higher.
Well, higher up, but they're not on the same plane as that earth point. They're
No,
further.
no. And for another reason, okay, facial nerve branches that are coming out, are those primarily sensory or are those primarily motor? Motor. So they're actually, as they come out from the parotid capsule, they wind up traveling under the muscles of facial expression and innervating them that way, which is typical for most motor nerves. They come in on the deep side of the muscle. You'll actually see this in this McMinn illustration. So here we see, now the platysma has been removed. We've seen this image before. So the platysma would have been coming down from here. Here's a masseter, here's a uncovered parotid gland that's out of its capsule. Here are all your facial nerve branches. Here is the temporal branch, the zygomatic branch, the buccal branches. Over here, the mandibular branch, the marginal mandibular branch, the cervical branch isn't there because the platysma's been cut out. Okay? So we're down here. Here's Erb's point over here. And so here is this great auricular nerve. Here is this lesser occipital nerve. And they pretty much are constant in terms of the position they take. We'll take a little bit, look at several other images of this as we go through this today. So this will actually be running parallel to a blood vessel on the outer surface of the sternocleidomastoid, okay? So what would you call a venous channel that was on the outside of the sternocleidomastoid? Jugular. Which one? External jugular. What would you call a venous channel that's on the deep side of the sternocleidomastoid? Internal jugular, okay? So external jugular will typically come in here. It actually drains into the internal jugular, but it will run parallel to the great auricular nerve. And sometimes actually we'll see venous interrelationships with some of the deep veins of the head up here, deep to the parotid gland, but also the facial vein coming down in here. Here's the facial artery, here's the facial vein. So then we've got this nerve that crosses over the top of the sternocleidomastoid and comes over here underneath the skin, okay? Now, these are, the illustrator here, or in this, before they took the photograph, they made sure that the nerves were lying flat. But what are they coming from? What are these nerves coming from? They're sensory nerves. They're coming from skin. So they basically laid them down in the approximate position that they would be. It's the same thing when we're dissecting the face, and we're looking for trigeminal branches. Some of them are quite large, and we could see some of the trunks. But as we remove the face, we remove the portion of the nerve that was innervating those portions of the face. For example, probably the most obvious ones that are still there are supraorbital and supratrochlear. Don't usually see a zygomatico-temporal, zygomatico-facial. If we go deep, we can see the infraorbital. And if we go down below this in relationship to innervation of the lower lip and the cheek and so forth associated with the third division, we'll see those large divisions deep in the infratemporal fossa, but we kind of lose them as we take the skin off of here. Well, this is the same thing. So they've laid these 5 of the 6 branches out here. Those are what we can usually see. They are coming out of the parotid capsule to innervate these muscles of facial expression, which are out here. Okay, this is a muscle of mastication. They're crossing over the masseter to get there. Okay, so great auricular, transverse cervical. Here we see the supraclavicular branches over here. Okay, here and here, and there's a little bit of one over here. Okay. But there's another nerve that comes into this field. Here's a supraclavicular here, here's a supraclavicular here, here's a supraclavicular here. But if you notice these nerve twigs here, as they're coming out, they're going under this muscle over here, okay? So this muscle is what again?
Trapezius.
Trapezius. What innervates the trapezius? What cranial nerve has
Spinal
trapezius?
accessory?
Spinal accessory nerve. So these are spinal accessory branches here, both from lower cervical sections, but also, once they've innervated the sternocleidomastoid, they come out under here, okay? This is the lesser occipital, okay? So let's label some of these on the McMinn illustration. I personally feel that as a photographic atlas, that this is more superior than any of the photographic atlases. And there are a couple of them in the lab, okay? So if you're in the lab and you're looking at things. All right, so here is great auricular. Here is transverse cervical. Here we see some of these twigs. Here's one coming back here. Here are two that are coming down here. These are supraclavicular. And this over here is lesser occipital. Okay, these twigs here, this one and this one, these are actually spinal accessory. Okay, so those motor or sensory or both? Spinal accessory nerve. If I asked you to tell me what kind of components are in the spinal accessory nerve, what would you say? GSA, okay, that's proprioception, okay. What are the motor entities, or what are the motor entities described of them? There's still some discussion about this. GSE, but also authors believe that at least the sternocleidomastoid muscle had some relationship to branchial arch 6. Okay, so they would be what? It would be GSE, they would be what? SVE. Okay. So that, you know, if you're taking an exam and I'm asking you that question, you would put them both down. Okay, you would put GSE from a motor perspective, but you would also put SVE from a motor perspective. Okay? And if I asked you what are all the components in that nerve, you would also add GSA. Okay? So that's still a little bit confusing in just in general anatomy. Once again, this is one of the cranial nerves that some people don't believe is really a true cranial nerve.
Can you explain how it could be SVE? I don't understand how it could be visceral if it's not.
Well, okay, what does SVE imply? Where do the muscles come from? Branchial arches, okay? So that's where that designation comes from, and it's believed that that this muscle, the sternocleidomastoid muscle, has a relationship to branchial arch 6, although most people who do the branchial arch tables typically leave it off, okay, because of the confusion. Confusion has to do with whether or not there are brain stem components associated with the spinal accessory nerve. The reason it's called spinal accessory is to believe the accessory portion of it is assisting the vagus nerve in whatever it's doing, including, we'll talk about a muscle in the pharynx called the palatal-glossus, which some authors feel can be innervated by the spinal accessory nerve, but most authors would believe that it's innervated by the vagus nerve. So this accessory portion has to do with its relationship to the vagus nerve. The vagus nerve has a relationship to branchial arches 4 and 6.
Can you explain the visceral part, like where the spinal accessory nerve gets that SV portion, the V portion?
Because it comes from branchial arches, which are another name for them is pharyngeal arches.
Okay. But
or
wouldn't
visceral.
the special be saying that it's from brachial
Why,
artery?
why are brachial arch musculature, why are they special? Is there any other place in the body where brachial arch musculature, skeletal musculature develops other than in the head? That's why it's special.
So is the S and the V saying that it's from the brachial arch? Because I'm getting confused of if the visceral is also saying it's from the brachial arch.
S means it's special.
Okay.
It's special because it's skeletal muscle that comes from a brachial arch. Why is it visceral?
Yeah.
Because it comes from a branchial arch. And branchial arches gives rise to muscles of mastication, muscles of facial expression, and pharyngeal muscles, which are associated with the head and pharynx, the throat, okay? And the E is, it's motor, primarily motor, or efferent violence, okay? Does that help at all?
Yeah.
Okay.
Thank you.
I have a question.
Yes.
So when something is labeled as visceral, that doesn't necessarily mean it's related to the gut, right?
It means it's related to some portion, and we're talking about the gut, we're talking about the tubular entities of the body that begin or continue as the airway, food tube, okay? Blood vasculature, all of those entities are visceral, okay? All of those entities are visceral, okay? In the head, we've got two large openings associated with the airway and the gut. We've got the nose and the mouth, okay? And they are surrounded in particular by muscles of facial expression. The jaws are moved by muscles of mastication surrounding the oral cavity and so forth. The spinal accessory nerve, if it has this vagus relationship, then it also may be, in its point of origin may be from branchial arches, and that's where all of the discussion is. It's not an easy nerve to trace either embryologically or through successive embryo mapping, okay? Okay. So if it surrounds or is associated with visceral entities, the nasal cavity, the oral cavity, the throat, then it's considered to have a visceral relationship. Yes?
Back to this picture, there's two nerves labeled 35, but it looks like you labeled one as spinal accessory and then one as supraclavicular.
That's true.
Like, see the spinal accessory, the bottom branch is also 35, and then there's one below it. So, like, which one?
Well, I think what's see here, there's actually two nerves here. There's actually two nerves here. There's actually another nerve here that's sensory as well. So this is supraclavicular, part of the posterior aspect. This is supraclavicular, this portion right here, and that is the aspect. So I would say that this larger trunk here is a spinal accessory. This is supraclavicular. This is supraclavicular over here. These are supraclavicular over here. This is supraclavicular. But this large trunk here, this is the spinal accessory. Okay. We'll see it on another couple of images. Okay, and we'll also see it in the laboratory. I think we may see it on this image.
So it's just the one large trunk? 'Cause I thought you were pointing at both, like, kind of the Y that you think,
No.
there's just one spinal accessory and all the others are supraclavicular?
Right. There's usually several because we're covering the back of the shoulder, the side of the shoulder, and the front of the shoulder. Down over the clavicle as well. So down over the upper portion, for example, of the pectoralis major muscles. Okay. All right, so this is a drawing. This is a photograph out of our lab. Here's sternocleidomastoid muscle over here. Here's the parotid gland, or what's left of it, over here. Here we've got, what do you think this is? What nerve do you think this is?
Transfer?
What's that?
The transfer?
That's a string tie on the blood vessels of the cadaver for embalming purposes.
Alright.
Don't make that mistake in a practical, usually we try. But here is the great auricular, okay, over here. You notice here, this is a venous channel coming up here. This is an external jugular coming. Typically can run very close to the great auricular, but it runs parallel to it. So great auricular transverse cervical. Here is a lesser occipital nerve coming out along the posterior border of the sternocleidomastoid. And then we've got kind of this milieu. This is a little bit of the trapezius muscle. Here is the spinal accessory, but these thinner branches here, these are supraclavicular. We don't have them all, okay, over here. Okay. So,
Can you go to the spinal accessory again?
yeah. So right here, that's the spinal accessory, whereas this is a supraclavicular. This is a transverse cervical. And over here, this is a, here's great auricular. Here's lesser occipital. Here's masseter over here, okay, platysma. It's kind of covered up now with the annotations, but what do you think this muscle is over here? It's actually gonna come here to the top of a bone called the hyoid bone, and it's gonna come up here underneath the platysma to attach to the nail. That's the digaster.
So can you say that like the spinal accessory looks like it runs more horizontally, and then the supraclavicular kind of like?
Well, you can try that,
Okay.
but don't think of it that way. Here's how you define it, okay? The supraclavicular nerve is part of the superficial portion of the cervical plexus. That's innervating what? Skin, right? So those are sensory nerves. Spinal accessory nerve is really not considered to be a sensory aspect other than its proprioceptive feedback, okay? So what's it innervating? It's innervating the sternocleidomastoid muscle, which we don't really see that. We'll see that in the lab, coming on the underside of the sternocleidomastoid innervated. But this portion that comes out to innervate the trapezius muscle doesn't come out on the top of the trapezius, it goes deep underneath the trapezius. So that's how you determine, for example, in the laboratory, what you're looking at. The cervical plexus nerves will be coming from the skin. The spinal accessory nerve will be going under the sternocleidomastoid muscle and then eventually going under the trapezius muscle. Okay. So that's how you would define that entity. We've got a couple more images of this. Okay, so once again, we've got, here's the sternocleidomastoid muscle, here's a great auricular nerve, here's a lesser occipital nerve, here's a transverse cervical nerve, here's some of the posterior aspect of the supraclaviculars or medial aspect. We don't see the anterior here. This might be one, but I'm not sure from this illustration. And I'm not sure here. Here's a little portion of the trapezius muscle. This may be spinal accessory coming down underneath it here. These muscles here are called scalene muscles. These two muscles here. Okay, we'll talk about those a lot today because those are rather significant in identifying other structures. These muscles that are a little bit farther back are part of what we call a part of the upper portion of rectus spinae. These are the portion of the splenius capitis muscle and the splenius cervicis muscle in here, okay, that these are traveling over. Okay. Not a great slide, but we had a great, you know, in terms of zoom in here, here's Herb's point, right here. Transverse cervical, greater auricular, lesser occipital, and some of the supraclavicular nerves here. And this is the external jugular. Greater auricular, lesser occipital, nerve there. Transverse cervical nerve there, okay? So we've seen this image before. It's on the closet. So we've seen this image before. Here, now, this is innervation of the face from the sensory perspective. Okay? So these are all, the nerve branches here are innervating what? They're innervating skin, but what are they coming from? What are going to? What is the cranial nerve they are associated with? These are trigeminal, right? The fifth cranial nerve. So here is the ophthalmic division, V1, mostly forehead and scalp and the bridge of the nose and areas surrounding the eye. V2, mostly cheek and upper lip with infraorbital, zygomaticofacial, and zygomaticotemporal. And then here the V3 branches associated with the innervation of the skin, the top of the auricle of the ear from the tragus on up, the buccal to the corner of the mouth where the cheek, the upper and lower portions of the corner of the mouth come together into the cheek. And this area, this is the lower lip, this is the mental branch. So this area here is innervated by trigeminal, trigeminal, trigeminal. This area here is not. This area here is innervated by cervical spinal. Here's the greater auricular, transverse cervical, supraclavicular nerves. Now in the back, behind this dotted line here, these are also innervating scalp and neck skin, but they are not anterior rami. They are posterior rami. They are coming off of these shorter branches anywhere from C2, actually C1 as well, but C2 all the way down to C5, and these are posterior rami. The largest one is great or occipital, and that will kind of overlap with the lesser occipital in front of it, but also with, at the peak of the skull, what we call the vertex of the skull or the scalp, with these supraorbital branches of V1. Okay? So the supraorbital branches of V1. Okay? So these are posterior rami, these are anterior rami, these are all cervical sensory nerves associated with cervical spine. Okay? But these are posterior rami, these are anterior. All right, so now let's kind of let's go a little bit deeper in here. And we not only have we removed the platysma muscle, we removed the sternocleidomastoid muscle. We have cut it. Okay. Here is the upper portion of it here. The mastoid process would be on over here. It attaches to the outside surface of the mastoid process of the temporal bone, and it will ascend from the clavicle. Here we see it hasn't been cut over here on the left side, but it has been cut over here. So from the clavicle and over here, and from the sternum over here, the manubrium, that's how it gets its name, sternocleidomastoid. Okay, and we see this black shadow image here. Okay, this is where it was. Now we see a lot of things here. We see venous channels, we see arterial channels that were sitting underneath the sternocleidomastoid muscle. Okay, we see some of the cervical spinal nerves that were associated possibly with the skin, but most of those have been removed with the skin. Here's the trapezius muscle here. Here you can see here the nerve. Some of these were supraclavicular, but you can see in the illustrators, you right here, this nerve here, and if you follow it, see it's going underneath the trapezius muscle. So that is the spinal accessory or the accessory coming under So this is a large vein that was underneath the sternocleidomastoid muscle, so what is it? Internal jugular, okay? And that internal jugular vein sits ensheathed in a deep fascia called the carotid sheath. Talk about that for a little while, okay? Sheath in an area called the carotid sheath, okay? And so this sheath is not only surrounding this vein, but it's also surrounding this artery, okay? So these two vessels live in this carotid sheath together. Also, there's a very large nerve we can't see here that is also inside of the sheath. So what gives it its name? This is the common carotid artery. Common carotid artery, internal jugular vein, lie within the carotid sheath. Now, lying on the outside of the carotid sheath, we'll see this in a lot. This is a very distinguishable nerve structure, nerve formation, okay? And if you look at it here, there is a twig that comes down here off of this large nerve over here, okay? And this large nerve coming down here is the 12th cranial nerve, or the hypoglossal. And as it comes down here, we'll see that it gives off a little twig to this muscle over here, which is this is the hyoid bone, this is the thyrohyoid muscle. It also gives a twig to a deeper muscle called the geniohyoid muscle. So that is actually, these are branches of C1. So why are they coming off of hypoglossal, or are they coming off of hypoglossal, or are they just traveling with it? So the hypoglossal is the 12th cranial nerve, right? So that's the lowest cranial nerve. So the next nerve below it would be coming from where? C1, the cervical spinal cord. But they're so close together that the deep fascia that holds that nerve trunk together is actually surrounding not only the hypoglossal nerve, but also C1. And so there's some confusion in anatomy. All anatomists don't agree. I don't agree with some of my colleagues. They don't agree with me. But as long as we can give the translation to you, okay, hopefully you'll have some idea what the hell we're talking about. So this C1 is sometimes what they say in relationship to this muscle or this deeper muscle, geniohyoid. They say it's not innervated by C1, it's innervated by the hypoglossal. Now, if you know where do the muscles of the hypoglossal nerve, where are they primarily? What are those muscles innervated by the hypoglossal?
Tongue.
The muscles of the tongue. The extrinsic and intrinsic muscles of the tongue. Where did they come from developmentally? From somites, right? Okay. What other muscles of the head came from somites? Remember the extraocular muscles? Okay, the extraocular muscles? Okay. So C1 is innervating musculature that also comes from somites here. These muscles we'll talk about shortly. These are what we refer to as the muscles below the hyoid bone, the infrahyoid muscles. Okay. So this is where some of the conflict comes in relationship to anatomists saying whether or not this muscle is innervated by hypoglossal or this muscle is innervated by C1. Okay. Most anatomists would say C1. We'll talk about it. All right, but this comes down and it forms this large string that is on the outside of a structure called the carotid sheath. And then we have, like, from C2 and C3 and C4, other branches that come and form a large string. And the two strings meet down here and they come together and they form a loop. They form a loop. So the anatomical term which describes a loop-like structure is ANSA, A-N-S-A. Okay? A-N-S-A. And since this is in the neck, we'll call this the ansa cervicalis formation, with a portion of the loop here called, since it descends from the hypoglossal nerve, descendens hypoglossi, and this back here coming from cervical spinal rami, descendens cervicalis, okay? So let's draw this in and then we'll take a little break. Okay, so I'm not gonna call this hypoglossal, I'm gonna call this C1. And I'm gonna call this descendens hypoglossi. And I'm gonna call this back here, I'm gonna call this descendens cervicalis. And these two entities here are going to come together to form a nerve formation which is known as the ansa cervicalis. Now the ansa cervicalis is deep, it's down there deep to the sternocleidomastoid muscle on the outside of the carotid fascial sheath. So this is the deep portion of the cervical plexus. Now, what is the functional difference between the superficial portion and the deep portion? Well, what did I tell you? The primary role of the superficial portion is sensory from the skin. The deep portion of the cervical spinal nerves are innervating these muscles in here primarily, these infrahyoid muscles. So it is motor to those muscles, so it is primarily motor. So where we took everything off the top here, we had the superficial portion of the cervical plexus. What we see down here in relationship to these nerve branches coming off here, primarily to these muscles, which we'll talk about shortly, we have the deep portion of the cervical plexus, and it forms this nerve loop, which we call an ansa cervicalis formation. And these, you know, one of the things that I hope you're getting the point of in the head and neck is there's things that are really small, but we can see them in the lab. Okay? So when you're going back and you're studying this after we've done, you know, initial demonstrations, you need to look, you know, that's why I said that in the last lab, I said you need to go back in there until you can basically know what the heck you're looking at. Because if you don't, you can't tell me anything about it, so you possibly can't answer the question I'm asking about the structure. So you gotta spend time in the lab. Okay. So most of you at this point in time are rookies, both from the standpoint of head and neck anatomy, but also from being in an anatomy lab. Okay, why don't you take a break? Why don't you take 5 minutes and we'll look at this a little bit more and then we'll go on. A little bit, and look at this. We're going to actually here, this is kind of a comedy slide from, this is also from Anatomy for Dental Medicine by Baker. So down here, here's your Erb's point. Here's the branches of the superficial cervical plexus. Here's the platysma muscle. They're coming from the skin back down through the platysma muscle, underneath it, coming down into this region we refer to as Erb's point. The only thing that's missing here is the structures of the carotid sheath. So all we're seeing is the deep components of the cervical plexus here. Here is the hypoglossal nerve coming down here, and here is C1 joining it, but then leaving it, okay? And there are two muscles here that can be seen. I think he's got the geniohyoid right here, and that's picking up a C1 branch over here. On top of it is these are the extrinsic muscles of the tongue. This is the genioglossus. What innervates that muscle? Genioglossus. Hypoglossal, okay? Hypoglossal, okay? Anything with glossal, okay, is tongue, remember that, or lingual. Okay? So this is the geniohyoid from the genoid tubercle to the hyoid bone. And this is now also innervated. This is a muscle called the thyrohyoid from the thyroid cartilage to the hyoid bone. We'll talk about some of these other ones soon. This is the sternohyoid and the sternothyroid and the omohyoid over here. And then these muscles here, this is a muscle of the pharynx. This is a inferior pharyngeal constrictor muscle that is coming around from the back to help form the posterior aspect of your throat, of your pharynx. Okay? But here is this ansa cervicalis formation. So this is C1 up here, and that is providing some rootlets that come down here to form this descendens hypoglossy coming from the area of the hypoglossal nerve. And then this is the descendens cervicalis bringing in C2, C3, and C4 comes in here at kind of a weird angle. So that will come in here to help innervate these infrahyoid muscles deep in the superficial neck region. Okay, another image, really similar but different, okay, in relationship to the ansa cervicalis formation. These are the infrahyoid muscles that it innervates. These back here, these are scalene muscles. We'll look at this in particular in relationship to another nerve complex called the brachial plexus back in here, okay? But here's an anterior scalene, here's a middle scalene. There's a little bit of a posterior scalene muscle here. Here, coming down here, remember C3, let me show C3, 4, and C5 form this nerve that runs down on the outside of the anterior scalene muscle and goes all the way to where? Where does the phrenic nerve go? To the diaphragm, both from a sensory perspective and a motor perspective. Okay? And then this ansa cervicalis formation innervating these infrahyoid muscles. Thyrohyoid, omohyoid, sternohyoid, sternothyroid. These are muscles below the hyoid bone. The geniohyoid is above the hyoid bone. It's a suprahyoid muscle up here. And there's some others that come into that category as well. So this is the ansa cervicalis formation. Okay. So let's look at the muscles of the neck in general. And we have these muscles, we have a posterior group of muscles that are in the back of the neck, okay? And these are this large muscle that covers up everything, the trapezius muscle, because it's shaped, it's trapezoid. It's trapezoid, okay? That's where it gets its name. Then deep to that is a flat muscle called splenius capitis, okay? Splenius implies a structure that's flat and looks like a bandage, okay? Splenius, literally defined, means bandage, okay? So this is the splenius capitis, and then deep to this is a muscle that comes off partly from the spines of the cervical vertebrae, but partly from the transverse processes. So it's called semispinalis capitis. It goes to the lower portion of bump in the skull called the inferior nuchal line. Then alongside of this, there is this other muscle that is out a little bit more lateral that comes to the back of the mastoid process of the temporal bone, okay? What was coming to the front of the mastoid process of the temporal bone? Sternocleidomastoid, okay? And coming from the back is longissimus capitis. So these two muscles here from the front, sternocleidomastoid, and here from the back, longissimus capitis, are helping to balance the head on the top of your cervical spine, either pulling backward or forward as you move through your environment. Then we have these muscles that are kind of scaled off the surface. We'll see these off the surface of the cervical vertebrae, primarily off of their transverse processes, and these are called scalene muscles. And there's one that's more anterior in position called scalenus anterior, There's one that is more posterior in position, but also deeper, called posterior scalene. And then there's one that lies between them called the middle scalene. We'll be looking at these shortly. Okay. And then we've got muscles that are on the vertebral bodies, and they are both coming from the neck, lower neck, and going to a higher region of the neck, possibly as high as C2, and then there's one that's going from the neck to the front of the base of the skull, basically in front of the foramen magnum. And these are called longus capitis and longus coli. Coli is a term that also means cervical, okay, or means neck. Then we have this large group of anterior muscles. The platysma is one because the platysma actually has an attachment from actually the lower jaw down to the shoulder. And this is the most superficial muscle in the neck. And then underneath this we have the sternocleidomastoid. It's from the manubrial portion of the sternum, from the clavicle attaching to the mastoid process of the temporal bone. And then we have muscles that lie above the hyoid bone. The hyoid bone, you know, in Thanksgiving, if you ever have the wishbone of the turkey, that's the turkey's hyoid bone. Okay. I guess if you're a cannibal, you would make that wish on a human's hyoid bone. But we are not, you know, at least most of us. So we have muscles that are attached to this bone. We'll show you one in the lab. I think some of you were in there, we showed it to you already. But these are muscles really from the lower jaw or from upper structures to the hyoid bone. The digastric, we'll look at the digastric. Digastric means two bellies or two heads, okay? That comes from behind the deep to the mastoid process of the temporal bone, goes down to the hyoid, and then ascends with its anterior belly to a little groove in the front of the mandible called the digastric fossa. Then there's a muscle that's right alongside it, parallel to it, called the stylohyoid, and the stylohyoid is a little bit deeper than the posterior portion of the digastric, and that attaches to the hyoid bone. Okay. Then there is a muscle that helps to make the floor of the mouth attached to, what were these ridges on the inside of the mandible called? They kind of bulge out from the inside portion of the mandible on the little tongue side. Those are called the mylohyoid lines, or internal oblique line. And that mylohyoid muscle on each side attaches from there to where? Where does it go? Where does it go? Mylohyoid. Goes to the hyoid bone, to the body of the hyoid bone in the front. Where do each one of the mylohyoid muscles from each side, though, attach to form a floor of the oral cavity with a intermuscular raphe. When muscles attach together really without a bone in between, they call it a raphe. This is called the mylohyoid raphe. Okay? And then there's this muscle that attaches these two little bumps in the back of the mandible. I call them the happy bumps because they're called genial tubercles. I don't know why they're so happy, but these little bumps on the inside of the mandible, one of them is attached to the tongue and allows the tongue to be attached to the front of the mandible. The other one is below this, and there's a muscle that attaches from this lower genial bump to the hyoid bone. That's called the geniohyoid. And then there's a muscle that attaches the lateral sides of the tongue to the hyoid bone, to these really great horns that are going backwards, and attaches to those greater horns of the hyoid bone. Okay? And then we have muscles below the hyoid bone, so we say they're not suprahyoid, they're infrahyoid. And there are 4 of these muscles. The longest one from the sternum to the hyoid bone is called sternohyoid. Then there is one that's a little bit shorter that attaches from the sternum to the thyroid cartilage, which is just below the hyoid bone, part of the laryngeal cartilages. And then there's a muscle called the omohyoid. Omo implies shoulder. The term omo implies shoulder. So it attaches from the fascia covering the scapula in the back and comes up at an angle, runs under the sternocleidomastoid, and attaches to really the midline lateral portion of the hyoid bone. And then there's a muscle that's kind of a continuation of the sternothyroid called the thyrohyoid, and this is also geniohyoid, the suprahyoid muscle, and thyrohyoid, this infrahyoid muscle, are innervated by C1 specifically. Okay? And so that goes from the thyroid cartilage to the hyoid bone. So now let's take a look at these muscles. Okay, so here's the sternocleidomastoid and the platysma and the trapezius. One of the things that we're going to see here in a second is that we've got some triangular relationships between these muscles here, okay, and some of the subsets of those. And we're going to talk about this as the anterior triangle of the neck. And this back here is a posterior triangle.
So the anterior is between the sternocleidomastoid,
And the midline of the neck.
platysma, and.
Midline of the neck.
Oh,
Here's the base of that triangle. Okay? Posterior is between the sternocleidomastoid and the anterior border of the trapezius muscle and the clavicle. These are two triangles. The clavicle is the base of this one. So if we look here.
Okay, so when one turns their neck just to the side, is it every muscle there that's involved or just the sternocleidomastoid?
Sternocleidomastoid primarily.
Okay.
It's the largest and more powerful, okay? But when muscles work, they have to work in what we call a synergistic fashion. In other words, they have to work together to get a smooth movement. So some of these other deeper muscles also are working in rotation in the neck as well, like these scaly muscles down in here, or even stabilizing the back of the head with this muscle here, the levator scapula or the splenius capitis, okay? That are also assisting in that movement. But also the sternocleidomastoids, you know, it's kind of like, remember the pterygoids? If they work together, they bring the mandible downward and forward, right? If they work just on one side, what do? How do they move the mandible? To the opposite side. This is kind of the same kind of relationship. This sternocleidomastoid contracts, it's going to pretty much rotate the mandible in one direction or another. Okay? In this case, if you do this here, the left sternocleidomastoid is going to rotate the head pretty much over, as it's coming down in an angle, to the opposite side. Okay? If both sternocleidomastoids contract simultaneously, what will it do? It'll bring your head or your chin down to your chest. Okay. Are these muscles important for chewing, for mastication?
Do they stabilize the movement?
Because they stabilize the head, okay? They stabilize the head. And so we need the head to be stable if we're going to be taking in food. We don't eat like dogs or cats where we shove our head or our mouth into the bowl. Oh, I don't know how any of you eat, so I'm not, you know, I'm just taking a wild shot at that. But we typically bring the food to our mouth, okay? Instead of bringing our mouth to the food. Actually, it's probably somewhat of a combination. We meet somewhere in the middle. All right. So here we see the sternocleidomastoid over here. See if this is still on. It's a minute. Okay. So here's the sternocleidomastoid. Here's the sternal portion, the clavicular portion. Here's the mastoid portion. You can see the highlight or the shadow of the mastoid process. Here's the trapezius muscle coming down here, also has a clavicular connection. And if you look at this space behind the sternocleidomastoid, it looks like a large triangle. But it's behind the sternocleidomastoid, so that's called a posterior triangle. Okay? If we look here, here's the midline of the neck. The skin's been cut at the midline of the neck. here is the hyoid bone over here. We can see a little bit of this muscle. This is the digastric. See a little bit of the muscle deep to it, the stylohyoid. And we see this muscle actually coming in from the back. This is part of one of the pharyngeal muscles called the inferior pharyngeal constrictor muscle. And then we see these muscles coming down from the hyoid bone. These are the infrahyoid muscles. But if we look at this triangle, the base of the triangle is your mandible, the lower portion of the body of the mandible, and it tapers down to the clavicle and the midline. So this is an anterior triangle. Okay? Now, if we look here, you see these structures here. It says anterior ramus of C5. C5 is part of what plexus of nerves? Any of you have had an anatomy before? What's C5 part of? What plexus? Brachial plexus. How far does that go down? How far does brachial plexus go down? Okay, cervical plexus went essentially from C1 or 2 down to C4. Where is C5 down to what? The brachial plexus. Okay, T1. T1. Okay. How many cervical spinal nerves are there? 8. Okay. Why? Why are there 8? No, there's only 7 vertebrae. But what's the uniqueness of cervical spine? The first one comes out above the first cervical vertebra. And then we go 2, 3, 4, 5, 6, and below 7 is C8. And then we get T1. That's the only place in the spinal cord where that happens. Everything else is below the vertebra that it's adjacent to. Okay. All right, so this is the anterior triangle, posterior triangle. This is a portion of this muscle up here, referred to as the omohyoid. This is the superior belly, it comes under here. This is the anterior scalene, this is the middle scalene. These are portions of the brachial plexus. These brachial plexus, we'll talk about this more next semester when we talk about the upper extremity, has rami, although a lot of anatomists still call these roots. I do not like that terminology with spinal nerves. But it has rami. The rami come together and form trunks. And then the trunks come together and form divisions. And then the divisions come together and form cords. And then the cords form the main branches that come to you, most of the lower portion of your upper extremity, from your arm on down to your digits. Okay. So if I've said this to you many times, you may not believe me, but the biggest anatomical problem that you're going to have as a dentist is your neck. Okay? Because if you start having issues with these spinal rami coming out of these vertebral foramen, or causing distortions of your neck, causing what we call spondylothiasis, or these kind of barnacles, okay? You may wind up, the function that it's interfering with is your hand. Okay? Anywhere to numbness, to loss of function. So all that stuff that Dr. Oceanero told you that you're going to try as hard as you possibly can to do is important to your survival as a dental practitioner or a surgeon, to be honest with you. Okay? That ergonomic. And as I told you before, your patients, you give it on. They want to be comfortable. They don't care if you aren't. Okay? And I'm not saying they do that maliciously, but they do that because they're people, and people are like that. We'd like to be comfortable. We don't care if the person sitting next to us is comfortable, but we want to be comfortable. So when your patient sits in that chair, they want to be comfortable. They know that you're going to cause them nothing but pain, right? They'll grip the sides of your chair. When they leave, you'll see their fingerprints still embedded in the arms, in the vinyl arms or leather arms of the chair, okay? So they're coming in, they're letting you work on this, they're tense. If they have, if they're a little bit rotund and they lie back, then their gut's pushing up on their diaphragm and they're having trouble breathing. So if you want to work on an upper posterior, distal occlusal of a second maxillary molar, you're going to have to do it like this. Okay? You see 5 of those in a day, and you won't be able to move your head up, okay? So think about that. There is some rationale to all of this to you. Yes, Brian?
When you were in practice, did you like take breaks between each client?
I tried. I tried. You know how you try and control your schedules now? That will follow you into practice. You know, you want to have a nice, even flowing schedule, but sometimes it doesn't work that way. Patient comes in late, that backs you up for the next 4 patients. Or there's a patient that calls that wants to be seen from an emergency perspective. So you fit them into your schedule, so now you've just added somebody into your schedule, okay? Controlling your life is like controlling a much bigger schedule than you're doing now, okay? So I don't want to discourage you, but I just want you to understand that organization of time for you is important here, but it's going to be just as important when you leave. And some of it has to do with your physical health. Your mental health too. I don't know if any of you are affected mentally by what's going on with you at dental school. As I said to one of the senior students, she was saying to me, you know, I go to sleep and I can't sleep, I'm having nightmares. I said, that happened to me. That happened to me. Or even now, I'll wake up in the middle of the night, I said, oh no, I gotta get that done, you know. All right, so this is an illustration of the cervical triangles. Here's this. Oh, now I'm finally do that. All right, so here is the posterior triangle over here, and you can see there's actually this omohyoid muscle coming through here. So there's actually 2 subtriangles here, and then you can see in front here's the anterior triangle, and you can see what the artist illustrated here is there's actually 4 triangles. 4 subtriangles in the anterior aspect. So let's look at some of those, okay? Okay, let's look at the posterior triangle first because it's a little bit more defined. I mean, there's only 2 subtriangles here. So the highest portion is back under your occiput, at the back of your skull. And so in there are what? There's superficial cervical nerves, like lesser occipital, okay, in that triangle. Some of the supraclaviculars are in that triangle. Spinal accessory nerve passes from the sternocleidomastoid to the trapezius muscle in that triangle. There are branches of arteries and veins associated with the musculature in that triangle that are part of the occipital artery coming to the back of your scalp and branching off or draining into either the external carotid artery or the external or internal carotid jugular veins. And then there's a posterior portion sometimes of this external jugular vein. Okay? So they're in the upper portion of this posterior triangle. Now then, this omohyoid muscle that comes from the front of the neck actually comes under sternocleidomastoid, attaches to the connective tissue of the shoulder, and comes down close to the clavicle and actually sets up a tiny little sub-triangle called the subclavian triangle. Why would you call it the subclavian triangle? What do you think's in the triangle? Subclavian artery and vein can be found in this triangle. In particular, by the way, on the right side, that is a little bit higher. Or it can be called the supraclavicular triangle because it's above the clavicle, or the minor vascular triangle. Any of you ever have a role of an anesthesia assistant, at any point in your time, or a nurse practitioner or anything like that, or a PA? Sometimes you have to go into that triangle to either explore, for example, the carotid artery from an end arterial perspective, look in it with an endoscope to see whether or not it's blocked, because you assume that because when you put the stethoscope over the top of where it is, you didn't hear any blood flowing. Or they're doing a major surgery on a large muscle mass in the lower extremity, for example, thigh musculature, total hip, total knee, okay, procedure, And they're going to be, for a while, they're going to be clamping those large vessels, and that's gonna change the overall blood pressure in relationship to your heart. So they put in a catheter in that down into your heart to determine what we call central venous pressure. Okay, whether that's changing, because that can change your cardiac output. All right, so they can go into that triangle, subclavian artery and vein are there in its branches, or, that's an interesting spelling, supraclavicular nerves coming through there from these lower or medial anterior portions of the cervical plexus. So these are the two triangles in the posterior, this larger posterior triangle. Now we go to the anterior triangle. There's 4 subtriangles here. So now we're in front of the sternocleidomastoid muscle. Okay? So underneath your mandible, the mandible is the highest or is the base of this triangle, this anterior triangle. And then it tapers down this way. Okay? From the midline of the neck back to the border of the sternocleidomastoid muscle. Okay? So we'll see all of this in just a second. So the digastric muscle comes down under the lower border of the mandible, also to a little bit of an extent in the back, the stylohyoid as well. Okay? And that muscle will form the second and third side of the triangle. The mandible, or the lower portion of the body of the mandible, is the base. The back portion of the triangle is the posterior belly of the digastric. The front portion of the triangle, coming from the hyoid bone, coming up here to this digastric fossa in your mandible, is the front portion of the triangle. So what's in there? Well, this large gland, salivary gland called a submandibular gland, sits in there. Also, there can be submandibular lymph nodes, okay? So in some of the cadavers we've looked at, we've actually seen some evidence of lymph nodes, okay? Why in some of the others we haven't seen lymph nodes? What does that tell you about that person at the time of their death? Well, they could have been removed, but it tells you nothing was going on from the standpoint of cancer, or nothing was going on from the standpoint of inflammatory response. Lymph nodes only react to a vector, okay? That vector could be bacteria, viral, it can be cancer, okay? What's the difference? Whereas a lymph node may swell due to bacterial or viral challenge, what happens to it in cancer? I saw in the schedule today, they had you do it, did you have a, like, I don't know why they put it on our schedule, okay? Like
In
some
cancer,
kind of
do you
video,
have-
did you have it in cancer? And
Well,
with
in
Dr.
cancer,
Stoyana?
You have, like, during metastasis, is that recognized as a problem? And then you would.
Absolutely. If it gets into the lymphatic system, it's a problem. But the cancer takes over the lymph node, causes it to become highly fibrotic and tied down to the surrounding tissues. So as lymph nodes that are swollen because of inflammatory process associated with bacteria or viruses may be tender, but it's soft and you can move it around. A lymph node that has been taken over by some type of cancer, whether it's metastatic or local, is tied down, is hard and doesn't move. So you're gonna find, puts you in a quandary if when you're doing a lymph node palpation, you find something like that in the patient, it really has to be explored. The best way to explore it is, first of all, to take a detailed history. The second best thing, if you're still not sure, is to go in and take the lymph node out and do a biopsy of that lymph node. Okay. So hard, fixed lymph nodes are not good. Okay. Lymph node, interestingly enough, cancer-invaded lymph nodes are not tender, but they're also not movable. Okay. All right, so, and you can't, with the parotid, we'll see an image, with parotid lymph nodes, you know, because one of Whitman's images shows parotid facial lymph nodes, okay? So something was going on in that person's face at the time of death. But usually you don't see the lymph nodes because the glandular structure of a lymph node, the glandular structure of a gland, for example, pancreas or submandibular gland or sublingual gland, kind of, it's indistinguishable from the gland versus the lymph node. But they're there, okay? So that's why we palpate. Okay? Facial artery and vein, we saw this. Remember how they ran through the submandibular node? So they're running through this triangle. Okay? And the lingual artery and vein also run through this triangle. Okay? And the hypoglossal nerve, as it's ascending to the tongue, runs through this triangle. Now, I took my first head and neck anatomy course was when I was in graduate school with dental students at Ohio State, okay? And the guy who taught this course was a little bit insane, okay? You may think I'm insane, but the guy that taught this course was kind of crazy. I mean, you know, he did things like put crushed bones in bags and asked you to go on the station and identify it, whether what the bone was and whether it was left or right or things like that. 40% of the dental class failed it. He didn't care. Okay. So, I do care. Okay. So these structures are running through there, but at the time, where dentistry was, for example, they were doing crown preparations. You have separating discs in your kits? These carborundum discs that you put on a slow speed handpiece? I mean, because when we started, we didn't have air-driven handpieces in the lab. We had belt-driven handpieces in the lab that we actually use in the clinic to do prophylaxis polishing. Believe it or not, I had a lot of hair when I was in dental school. So I remember a couple times leaning over this, holding the belt-driven handpiece, and my hair getting caught in the belt. Okay, that was painful for me. And the patient was doing okay, but that was painful. But these separating discs we used a lot for lab work, you know, for cutting through things, even metal. So they used to use them instead of carbides or diamonds for cutting tooth crown preparations. Now, slow speeds, if you haven't noticed, have more torque than high-speed handpieces. They grab something and they will jump. Okay? So there were occasions where dentists over the, you know, many years ago, when it jumped into the tongue. And the tongue started to bleed because the lingual artery is actually, we'll see, it's quite a large artery. Okay? So they used to teach the students there's a subtriangle in the submandibular triangle called the triangle of Lesser, okay? And what our anatomy instructor, this guy at the time, said, if this happens, you've got to dissect down through the submandibular triangle into the triangle of Lesser, and you've got to ligate the lingual artery. And we're looking at each other like, you got to be out of here. You got to be out. You're going to do that in a dental chair? That's what phones are for. Those three little numbers, 911.
Right.
Okay. So, and actually, there's a better place to ligate it if that's what you have to do. But these entities are inside this subtriangle called the digastric triangle or the submandibular triangle. Then we've got this triangle that also sits just in front of the anterior border of the sternocleidomastoid, and it's called the carotid or the major vascular triangle. Okay, so now what's under the sternocleidomastoid again? What's this large ensheathed group of structures underneath the sternocleidomastoid called? Carotid sheath. Okay. So lying inside that sheath is a common carotid artery. It's going to branch into two large arteries called external and internal, giving off, internal just goes up to the brain. External gives off all of the branches outside to the face and the neck. The lingual artery is a branch of the external carotid. The lingual vein is a tributary into the internal jugular. The facial artery is a branch of the carotid. We'll see this on an image shortly. the vein drains into the internal jugular. The internal jugular vein is draining all of the veins from above, including brain, the vessels coming from the cranial vault, okay? So all of those are eventually draining into internal jugular. But also in there are the hypoglossal nerve, actually at this point passes across the carotid sheath as it's coming down, then ascends into that upper triangle, the submandibular triangle, to get to the tongue. So it actually comes in there and loops up. The vagus nerve is in that sheath. So the three large structures are in that sheath. Okay. The common carotid artery, the internal jugular vein, and the vagus nerve, cranial nerve 10. So there's a lot of significant structures in there. Okay? That's why the vasculature, the two very large vessels, that's how it gets its subname, the major vascular triangle. Okay? But all of these structures are in there. Okay? So, you know, in relationship to triangles in the neck, this is really something that evolved probably more from medicine than dentistry. It's not that dentists don't typically do neck procedures, but that wasn't something, or isn't even something today that they typically participate in. Although if you go into an oral maxillofacial surgery program, if it's got an MD aspect, you're probably going to be at least assisting in those surgeries with the ENTs, the otolaryngologists, and doing lymph node dissections and things like that. Those are things that you have to know where they are. You have to know what's in that triangle. Okay, so these are two of the four anterior triangles. Okay, so then there is a triangle that's underneath your chin. So as the digastric anterior belly comes up to attach, basically from out here to here, it forms one of the borders of the triangle. And the other border is the midline of the neck. And then the third border is your hyoid bone. So this is below your chin, your menton, your submental. So what's in there? Well, the floor of the triangle is the mylohyoid muscle, attaching from the mandible to the body of the hyoid. But also in there are vessels that are sub-branches of the facial artery and sub-tributaries of the facial vein in there, coming from the anterior aspect of under your chin. But also, there's typically a solitary lymph node on each side of the midline, called the submental lymph node. Okay. Now, where do you think that might come into play when you're palpating lymph nodes? Where do you think you might find that actually more often than not? What would the condition that the patient would be demonstrating to you as a dentist? What condition would a patient with enlarged submental lymph nodes be demonstrating to you? What kind of condition do you think that they would be manifesting more often than not? Right. Periodontal disease, okay? The anterior lower lip, the tip of your tongue, and the periodontal mucosa and gingival and dental tissues here drain into the submental lymph node. Okay. So if you want to know how severe the periodontal problem is, if you're feeling a lymph node, you're getting invasion of bacteria into the systemic circulation from these involved lower anterior dentition. Drilling, billing, and filling is not the only role that a dentist plays, okay? All right, so that is a submental triangle. Then there's a muscular triangle. Now, interestingly enough, if you really look at it close, it's not a triangle, okay? It's like a rhomboid. It's got four sides, none of the sides are equal, okay? But it comes close enough to being a triangle that they still look at it. Now, it's called the visceral triangle. Okay. So what kind of structures do you think are associated with this? What's viscera? What are visceral tubular entities?
Associated with the GI tract.
Anything else?
Nasal cavity, oral
Comes from
cavity.
brachiorachis.
Okay. But how about the airway?
Airway.
Okay. How about the airway? How about the larynx, the trachea? Okay. Those are visceral tubular structures as well. So one of the borders of this triangle is the underside of the body of the hyoid bone. The midline border is the midline of the neck. The anterior border is the posterior border is the sternocleidomastoid. Okay. And actually part of the border, there's actually a fourth border, and that's the clavicle. Okay. So what's in this triangle? Well, infrahyoid muscles below, these strap muscles below the hyoid bone. The larynx and its cartilages are in here, this protective mechanism for the airway. The thyroid gland is adjacent to the cricoid cartilage, which is down below the thyroid cartilage. The trachea, the major portion of your airway going to both the left and right lung. The superior and inferior thyroid arteries and veins, which are branches of the external carotid. The superior laryngeal nerve, which is a branch of the vagus nerve. The recurrent laryngeal nerve, which is a branch of the vagus nerve. Have you seen that nerve before? Have you seen the recurrent laryngeal nerve before? Where did you see it? Where? What was one of the first sessions you had? What theme was that?
Heart.
Heart and lung, okay? Recurrent laryngeal nerves come on the left side, it wraps around the aorta and goes back up. On the right side, it wraps around the brachiocephalic or subclavian junction, goes back up. What does it innervate? Primarily.
Ceroid gland.
What?
Ceroid gland.
Okay. Okay. Is the larynx made up of skeletal muscles? Okay. The muscles, intrinsic muscles of the larynx. If you had a patient that had a weak voice, and initially to them they think they're hoarse, or you may initially think they're hoarse, but really, if you look at their throat, there's no inflammatory process going on. Okay. So what could be going on? Recurrent laryngeal nerve, typically on the left side, can be being stretched by an aorta that's internal and external surfaces are split and creating an aortic aneurysm, which is bulging out and stretching the recurrent laryngeal branch of the vagus. There's actually a disease state where that's rather common. It's called Marfan syndrome. It's typically in males. Okay, but one of the things they have is dissecting aortic aneurysms. Okay. Do you know anybody in history who had Marfan syndrome? Huh? Abraham Lincoln. Abraham Lincoln. So John Wells Booth didn't tell him that disease would have gotten him shortly after. Because usually they don't live past their late 40s. Okay. See, this does have some relationship to clinical dentistry and medicine. Okay? That's what I'm trying to get at. Okay. All right, let's look at some of these triangles, and then we'll take another break. Okay, so once again, here note we got an anterior view. Sternocleidomastoids have been taken away on both sides. Here are structures associated with the carotid sheaths over here. Those are the internal jugular vein and the common carotid artery. We see these infrahyoid muscles here. This muscle here coming from the sternum going up to the hyoid bone. That's that kind of light colored, light yellow colored area. And that is the this is the sternohyoid. Then there's a muscle that's deep to it that comes up here. The sternohyoid's been cut away over on your right. And this muscle coming up here and engaging another muscle on the outer surface of the thyroid cartilage, okay? That's called the sternothyroid muscle, okay? And the muscle that continues from the thyroid cartilage to the hyoid bone, and you can see there's an intermuscular raphe there, which kind of looks like a tendon where the two tendons meet. And that's called the thyrohyoid, this muscle up here. Okay? That muscle up there. Okay, so sternothyroid, thyrohyoid, sternohyoid, and then we have this two-bellied muscle, the omohyoid, which travels under the carotid sheath, over the carotid sheath, but under the sternocleidomastoid muscle. Here's the shoulder over here. This is the inferior belly. Okay, so there was superior portion of the posterior triangle, inferior portion over here. Then it comes up to the hyoid bone and attaches to the hyoid. Okay, so these are what we refer to as being infrahyoid muscle. Sitting in between them, left and right, here is the cartilaginous rings of the trachea. Here's the thyroid gland, okay, down here. Here's the cricoid cartilage. Here's a cricothyroid membrane or ligament. There's the thyroid cartilage. And then between the thyroid and the hyoid bone is the thyrohyoid membrane. Which one of those is more significant from a clinical perspective? The thyrohyoid membrane or the cricothyroid membrane? If you had a patient that all of a sudden had an upper laryngeal obstruction and you couldn't relieve that obstruction, what would you do? You'd make an opening. Where would you make the opening? Through which membrane? Thyrohyoid membrane or cricothyroid membrane? Why? Because what happens if anything hits the vocal folds, they close, or that's upper laryngeal, okay? So if they're closed, it doesn't do you any good to go through the thyrohyoid membrane. You want to go below the vocal folds, okay? So, even they used to show this in westerns when the cowboys are fighting the Indians, and some cowboy got knocked off his horse and had a crushing of his upper larynx or something like that, and his buddy came there with a little tip of his Bowie knife, opened this little opening through the cricothyroid membrane called a cricothyrotomy, found a feather from one of the Indians lying on the ground, cut off both ends, created an airway, and put it in. Okay. See, everybody uses anatomy, but not everybody knows what we use it for. Okay. For the most part. All right. So this area here. This is the crico. We'll talk about this again. Thyroid membrane, or another name for it is the conic ligament that surrounds that, and that's what you would go through because it's below the vocal folds, and you can open an airway. Now, the other thing associated with this is this, okay? So why do we have this relationship? What are these structures, what are these muscles for the most part moving? What are they moving? They are attached in some way to structures that are interconnected to your airway. Okay? What happens when you swallow? We already did part of this exercise once, remember, okay? We'll do it again. Try swallowing with your mouth. Okay? It's not easy, is it? okay? Not easy, okay? So when we swallow, typically our lips and our teeth and our jaws have to be together to have a more effective swallow. And why is that? Because we have to stabilize the movement of the tongue, okay? And then the tongue is gonna form this little ball of food called a bolus, and see that it gets back into the food tube. Now, where is the food tube in relationship to the airway? It's behind it. So we're constantly having to move this food around the airways somehow, or possibly over the top, which we typically, by the way, don't really do, over the top and into the food tube. So in order to do that, what do we have to do? When we close our jaw, what does the mandible do? It pulls up and forward on the hyoid bone, which brings the thyroid cartilage and the other laryngeal cartilages, excuse me, in the airway, you may have to do this again, and the airway forward, upward and forward, and pulls it a little bit farther away from the food tube, so that we can more successfully swallow. Okay. So we can more successfully swallow. So we have these balancing rods of muscle. Omohyoid connecting behind to the area of the scapula, sternohyoid, sternothyroid coming up to the hyoid bone, the thyroid cartilage from an anterior perspective, pulling a little bit forward on the airway. The geniohyoid and mylohyoid going up and forward on the airway. So trying to stabilize the airway so that we can successfully swallow without doing what we call aspirating, bringing something or breathing something into our airway. Whether it's a food, the crown you're trying to see, okay, the endodontic file, I understand you had a lecture from an endodontist, endodontic resident. So these are things that can get into the airway. Now, if anything hits the larynx, hits the laryngeal muscles, they go into spasm, they contract. If they contract, they have closed the airway. Okay. So, we'll talk about this again when we talk about some of the pharyngeal structures. All right, here's a muscular view. Over here, looking at these structures. Once again, over here, sternocleidomastoid still in place. Okay, what's this? Oh, doesn't show well. Let's forget about that. We're gonna cut away. Okay, so here is, for example, sternohyoid. That's number 12. Running under it was 11 is sternothyroid. You can't see where it's attaching to thyrohyoid. Number 8 is the superior belly and the omohyoid. Up there, we see 13 is the thyrohyoid membrane. The thyroid cartilage is covered up by that thyrohyoid membrane. The 30 is the cricoid cartilage. 29 is the thyroid gland. I don't think they really show. Yeah, they kind of have pulled back the sternohyoid here. Okay, we've got the sternothyroid, and 12 is the thyrohyoid. And you can kind of see the little ligamentous raphe in there between sternothyroid and thyrohyoid. Okay. All right, so why don't you take another break? Want to look at muscles in your patient who has good definition. And remember we talked here, he is a little bit of a started a six-pack here, you know. So, but as he puts tension on his neck muscles, you can see not only some of the neck muscles like sternocleidomastoid and trapezius, but you can see in some of these triangles, like here you can see posterior triangle, the subclavian portion over here, okay? So, and you can see anterior triangle region. So, this is Lockhart, this guy Lockhart who wrote this anatomy text, His first book was all photographs. Now, when I say photographs, I don't mean digital photographs. I mean photographs that had to be duplicated in textbooks, which was much more difficult to do at that point in time, which was all black and white. Okay? Doesn't mean that it was bad, but it was harder to do at that point in time. Now, digitally, you can almost do this yourself in your bathroom. You know, look in the mirror, take a picture. I think I told you, one of my mentors, neuromaxillofacial surgeon Dan Burn, was one of the premier surgeons, at least in Greater Cleveland, but also in the United States. One of his lectures that he would give to his residents in relationship to, for example, muscles of facial expression. He was actually an excellent artist as well. And he, in the mirror, he drew them or painted them on his face. And then went to give the lecture to his graduate students to show them where the muscles were. And he would go, you know, he would try and get it so that when he made that expression, the muscle that made that expression move. Very clever, okay? Very clever guy.
Are you gonna do that for us?
No. I'll just draw the risorius, you know, the laughing muscle.
Why so racist?
All right, so let's look at some of the vasculature associated with the neck. All right, we talked about it a little bit so far. So we've got branches of, that should say common carotid artery, the internal carotid artery. Where does that go? To the brain. Does it give off any branches until it gets inside the skull? No, not on one. Okay, there's some challenges to that, but that's, you know, certainly there's anomalous type formations in a lot of individuals. What I would say to you is, for example, if it's not broke, don't fix it. Okay? You know, so if you see an extra cusp on a tooth, you know, don't get crazy. You know, don't say, oh, we gotta grind that down. Okay? Or something like that. You know, same way with when you're looking at a patient from the standpoint of plastic surgery and things like that. The patient's the one that's gotta bring it to you that they're concerned, okay? Before you even have a reason to do anything. If they're functioning well, they're functioning well. So then external carotid is what gives off all of the branches to the face and the upper neck. So the first branch is the superior thyroid artery off of the external carotid. That's just after it splits at the carotid sinus and becomes internal and external. Internal a little bit more posterior, external a little bit more anterior to the split. There is many times a middle thyroid artery that comes off the superior thyroid. So where is this artery going? Where is it going? Superior thyroid, middle thyroid. Thyroid gland. Thyroid gland is a highly vascular gland. Okay, highly vascular gland. Okay. We'll see that there's actually branches from the subclavian that come up to it from below. Okay, after the superior thyroid, there's the lingual artery. Okay, now we're going to see this in a minute, but the lingual artery has a relationship, a constant relationship with a nerve that runs parallel to it, called the hypoglossal. And the two structures are separated by a muscle of the tongue that comes from the lateral border of the tongue and attaches to the greater horn of the hyoid bone, and that's called the hyoglossus. And the nerve runs deep to it to go to the muscles of the tongue. The artery runs, I'm sorry, I take that back. The nerve runs superficial to that muscle on the outside of it, and the vessel, the lingual artery, runs deep to it. And we can actually follow that into the oral cavity. We'll see that relationship in the laboratory. Okay, yes.
Wait, can you repeat what runs deep? to the muscle?
What runs deep is the lingual artery. What runs superficial to that muscle is the hypoglossal nerve. Then the facial artery, next branch, it also, before it gets up onto the face, goes running through the submandibular gland, gives off a branch called, it's really submandibular and then submental artery. And then there's an artery that runs deep off of the external carotid, deep to the facial artery, and that's called ascending pharyngeal. Where does that go? Talked about this before. Where does that go? Ascending pharyngeal.
There next.
Okay, remember we had this place that a lot of anatomists say nothing goes through it. What's that opening in the skull called? Foramen lacerum. This actually goes through the foramen lacerum, through this connective tissue in the base of the skull, and helps to provide some blood to the middle cranial fossa, ascending pharyngeal. Also on its way up, it has little vascular branches to muscles such as the superior and middle pharyngeal constrictor muscles. Then we have the occipital artery, one of the hardest arteries to find in the head neck, okay? The reason for that is it branches off of the external carotid and it runs deep to the sternocleidomastoid muscle, literally running under it where it's attaching to the mastoid process and comes out in the back of the scalp. So it's a real hard muscle to dissect for. We'll try to at least get its beginning coming off of the external carotid. Then there's an artery called the posterior auricular, which basically runs somewhat parallel to the lesser occipital artery and runs to this area of the skin behind the auricle of your ear. Okay. Then we have this branch, this large branch that goes deep into the face. What does it run deep to? Okay, it runs deep to the mandibular, the mandibular condylar neck. Okay. But it's called the maxillary artery. Have you ever gone back and looked at old anatomy books, very old anatomy books? Okay. What was the mandible called before it was called the mandible? Submaxilla. Okay, so here, this artery that is really going into this space, this infratemporal fossa space, was named in relationship to the submaxilla. This was the maxillary artery. And it runs directly on the inside of the mandibular condylar neck. Mandibular condylar neck fractures can be pulled by the lateral pterygoid across this artery and lacerate it. So you can get a major bleed into the infratemporal fossa and lose blood supply to a lot of structures. Okay. You should try and figure that out now for yourself because you may get that question. Superficial temporal artery, you can actually see that very well on the cameras. You can see it very well on yourself, okay? Because it kind of bulges off the surface of your skin as it's coming up to supply the upper scalp. So it's like a tree, looks like tree branches. And you can see that in the mirror on yourself as well. Probably guys more so than women, okay? But it's interesting, this is a vessel that many times, for whatever reason, they're still thinking about why this happens, because of conditions like migraine, where all of a sudden it dilates, okay, and starts to stretch, for example, the auriculotemporal nerve branches that are coming over here and causing a lot of lateral head pain.
Is that the artery that like pulsates when people are angry?
Yes. Yes. Are you angry right in that? You should see that. All right, so let's look at these. Okay, so, try and go, see if I can go full screen on this. All right, so common carotid. This is the carotid sinus. What's happening there? We already talked a little bit about, we actually talked a lot about this in our
Baroreceptors, chemoreceptors,
baroreceptors with baroreceptors monitoring.
blood pressure,
Anything else being monitored in there?
chemoreceptors,
pH, what are those being moderated by?
chemoreceptors,
Chemoreceptors, okay. So what would cause a change in pH?
carbon dioxide.
Carbon dioxide? Hypercapnia or hypocapnia, okay. So, then coming off of the back here, this is the internal carotid. And then this in the front. This is the external carotid. Okay, so, right here. So now, all of the external branches of this carotid arterial system are going to be given off. So the most superior branch is right here. So this is the superior and possibly middle thyroid. Now then, the next branch is, coming off here. And as I put some back there, the higher bone still intact. We've got a better slide than this. But there's a muscle that is coming down here and covering it up. And this is the hyoglossus. And this vessel that's coming in underneath it, that is the lingual artery. Okay. And then just above it is a vessel coming and winding its way onto the face. And this is the facial artery. Here is this SCM here, sternocleidomastoid, and coming off here deep to the sternocleidomastoid and coming underneath it to the back of the scalp. This is the occipital. And then the back part of the mandible and the ramus have been removed, including the condylar neck. So this vessel coming in here to this infratemporal fossa, this is branching here, down here, okay? This is the maxillary. And then continuing up to the outside of the scalp. This is the on the side, superficial, temporal. Okay, so what are these muscles here in this deep space, this infratemporal fossa, feed to the mandible? So what's the maxillary artery running over the top of? What's that muscle in the back? Okay. What do you think? What do you think that muscle is? Oh, there's dead, so. So this muscle here, what do you think that is?
I can't even see what it's.
Okay. All right, what do you think this is? There's a
Can you
cube.
switch colors?
I can't switch colors, that's what drives me nuts with this. For some reason, Windows 10 will shift my arrows and everything all over the place. I'm still working on that. Okay, so the back dot, what's between them? You see that Rafe? You see that Rafe? What's that Rafe called? I don't know if you can read it on the slide. What two muscles are intersecting here? What's the back muscle? Is it a muscle of the face or is it a muscle of the throat? Right, superior pharyngeal constrictor. What's the muscle in the front? No, that's even more forward. It's a bucksnake. See, if you look a little bit, that little yellow dot above it, that's the parotid duct. So that, the face called the pterygomaxillary raphe. I'm sorry, pterygomandibular. Pterygomandibular raphe. Have any of your instructors talked about that yet? Okay, we will talk about local anesthesia probably before anybody. But you want to inject lateral to that when you stretch it in a person's mouth. Make sure your needle goes down to the bone on the inside of the ramus to guide it back to do a inferior alveolar injection. So it's something that we use as an anatomical landmark in relationship to guiding our inferior alveolar injection. Okay, let's go and look at another artery. Okay, so this carotid is taking care of pretty much this area from your thyroid gland up. Okay, but then we have this area associated really more so with the deep neck, or this area just above the clavicle called the root of the neck. And these vessels here are associated with a little deeper vessel called the subclavian. Okay, what does subclavian mean?
Lower clavicle?
What does it mean? It means deep to the clavicle, right? Okay. So the subclavian has some interesting vessels as well. We talked a little bit about them over the course of this year. Its first branch, its first superior branch is called the vertebral artery. Okay? Its first superior branch is the vertebral artery. We talked about this when we were talking about the blood supply to the brain. How does the vertebral artery now travel from the subclavian to the cranial vault, to the brain? How does it get there? How does it get inside the cranial vault? What does it travel inside? We're going to look at those in a little while. The cervical vertebrae have an opening in their transverse process called transverse foramen. So developmentally, it's too close to catch the 7th cervical vertebrae, but it catches the upper 6 transverse foramen of the cervical vertebrae, and then after it leaves the first cervical vertebrae transverse foramen, where does it go? Foramen magnum. Okay, that's the vertebral. What's the first inferior branch? I told you that the other day too. What's the first inferior branch? You saw that last semester, once again. When should you start studying for boards? Okay. Probably sometime this summer. Okay. That's the internal mammary or internal thoracic that runs parallel to the sternum on the inside. That's the first inferior branch of the subclavian artery. All right. Now the second branch is called the thyrocervical trunk. So what is that saying? It's saying maybe associated with the thyroid gland and the deep neck. Okay? And when we're talking about a trunk-like formation, we're talking about an artery that has branches like a tree. We have a trunk of the tree and we have branches of the tree. These are not large. Okay, these are not very large, they're not very long. But this is called the thyrocervical trunk, and it typically has three and a half branches. The suprascapular, which runs along the inside of the scapula and back over the top of the scapula. We haven't really done upper extremity yet or looked at the bones there. But have any of you looked at upper extremity bones in the past in any of your courses? There's a notch there called the suprascapular notch. And what goes through there? Okay. Nerve called the suprascapular nerve, which innervates muscles on the posterior surface of the scapula, but the suprascapular artery, which supplies those muscles with blood. Okay? And then there's a nerve that an artery that changes names, that runs through this space, through the next space we'll be looking at shortly. That runs transversely. It actually runs across the brachial plexus. And then it goes along the back border of the scapula and changes its name from transverse cervical to dorsal scapula, where it runs along the medial or posterior border of the scapula. And then there's a small branch that goes to the thyroid gland, which is now not coming from above, but coming from below. So this is called the inferior thyroid. And sometimes there's an ascending cervical branch, which is a little bit deeper, that takes care of some of these deep muscles, for example, scalene muscles, or possibly you'll see some other muscles like longus capitis, longus colli muscles. And the next branch is really tiny, very hard to see, usually deep to thyrocervical trunk, and it's called costocervical. Okay, what's the costa? What does costa refer to?
Ribs. Oh, ribs.
Ribs. Okay. So this actually gives off the highest or superior intercostal artery between the first intercostal space, and it gives off a deep cervical artery, which also runs to these deep cervical muscles like longus colli. Okay, so these are the subclavian branches. Now, a lot of the images I show you in many ways are distorted from what we're really going to see in the laboratory, okay? Because they're greatly enlarged compared to what we would see in the cadaver. It's even the same thing with the holographic images. We looked at this kind of blown up holographic images, for those of you that were over there, so that we were able to see what we were looking at. Okay? This is kind of the same thing. If we got a little tiny image, it would be harder to see, harder to define. So this is the subclavian artery. Here it's coming down into the upper extremity. Okay. Here it is branching. This is a left side. Okay. So what's it branching off of? What's the left subclavian artery branch off of?
The superior vena cava?
Artery.
Aorta?
The aorta. When you take a blood pressure, would you expect the blood pressure in that individual to be a little bit higher on the left or the right? The left. Because the left is a direct branch of the aorta, the right is an indirect branch, basically coming off of this common vessel called the brachiocephalus. However, the way our chairs are set up, they're mostly set up for right-handed practitioners, so most of the time you take it on the, wind up taking it on the right side. But when you're taking a blood pressure, if you find that it's high, you should still, even though you would expect it to be higher on the left, you could still take it on the opposite side. So that and after, just before, you're gonna take the radiograph so that you really know that you're getting a more accurate reading. All right, so where are all of these branches coming off? Okay, so this is the subclavian. What's this vessel? Common carotid. What's this nerve? What structures are in the carotid sheath?
Vagus nerve,
Okay, what else? What's been cut out?
external carotid, and internal jugular.
Common carotid, vagus nerve.
Internal jugular.
Okay, so this is the vagus. Okay? So, this subclavian is going to give off a few branches here, coming off of this little trunk. Okay, that is the thyrocervical trunk. Here is the suprascapular. Here is the transverse cervical. All right. So that branch crossing these yellow cords, which is the brachial plexus, that is a transverse cervical. And then there's a branch coming up from there, going towards the thyroid gland over a muscle called the scalene, that is the inferior thyroid. Now, the vertebral is just, if you look at the image, is on the right side of the vagus nerve. Okay? And that's the vertebral, very deep. Okay? So we look at this in the lab. Okay? Don't go looking out here for branches of the subclavian. The subclavian is only under the clavicle for a short period of time. So we're talking about maybe an inch of where the subclavian branches are being given off. What does the subclavian change its name to as it comes down in here? What does it change its name to? It goes into the armpit.
Axillary?
Axillary. Okay. So just where that dot is, where all of these subclavian branches are being given off. And they are adjacent to, let's see if I can get this thing going again. No idea. Display symbols. Let me just do something. Try to do something. So behind that little circle where that thyrocervical trunk is gonna be the costocervical trunk. And you can see there's some other things in there, okay? So right next to the common carotid artery is what again? What nerve? Okay, now, if you go right behind that thyrocervical trunk, you see another nerve. What do you think that is? What do you think the muscle that it's running over is called?
I'm not sure where you're pointing.
Accessory.
Pectoralis.
Above the vein, attaching to the clavicle, attaching to the rib, actually. Sternocleidomastoid is gone.
Accessory.
Okay, it's one of these muscles that we call scalenus. It's the scalenus anterior. What nerve do you think that is running over the scalenus anterior? Look at where it's coming from. What cervical ring line it's coming from. C5 and higher. Phrenic. So that is running over the anterior scalene. That's the phrenic nerve. That's a constant anatomical relationship. If ever you see that in the laboratory, one defines the other. The phrenic nerve is running over the outer surface of the scalenus anterior muscle. Okay. Or the scalenus anterior muscle is running deep to the phrenic. All right, let's look at some of the venous structures. Okay. All right, so okay, so here now they've cut a window in the platysmal muscle. Okay, the illustrator's cut a window in the platysmal muscle. So what do you see? What's that muscle crossing under the platysmal muscle? This muscle here. What is this? Okay, what are those nerves that are passing in relationship to the sternocleidomastoid? Spinal nerves, but what particular portion? Is it a plexus?
The cervical.
Okay, what's this point here?
Herb's point.
So that's the cervical plexus. So you see the transverse cutaneous or transverse cervical nerve. You see the great auricular nerve. What vein is running parallel to it? Crossing the path of the sternocleidomastoid.
Jugular and internal jugular.
External jugular. Okay, external jugular. Okay. That little nerve that's back behind the sternocleidomastoid, what is that called? Well, the great auricular is running parallel to the jugular vein, over the top of the
One
sternum.
behind that one.
One behind it, the posterior border,
Lesser occipital.
lesser occipital. Now, what's that vein that is behind that? See the label? That's the sometimes there's a posterior external jugular vein. So this over here, posterior external jugular. Okay. Here is a transverse cervical artery and a transverse cervical vein. Okay. Here is a subclavian artery and a subclavian vein. This is what triangle? Here's the omohyoid. What do we call that triangle? Subclavian triangle, right? Okay. These vessels here that are running up the front of the neck or actually down the front of the neck. These are called anterior jugular arteries, anterior jugular veins, I'm sorry. Anterior jugular veins. What is this space here on the top of the sternum?
External notch.
Jugular notch. What venous channel is running across the jugular notch? Transverse jugular vein. Transverse jugular vein. Okay. Okay, so here's an anterior view. So here are these vessels. What's this large vein? The sternocleidomastoid's called. Internal jugular. And then here's the external jugular draining into it over here. Here are the anterior jugular veins. Okay. What do we know about all of these veins? Do we have a valve yet?
Nope.
No. Okay. These are avalvular. Okay. What's this nerve loop called? On top of the carotid sheath, on top of the ansa cervicalis formation. Okay, here's another view, and we see, what we see here is an interesting relationship. Okay, so between this large vein and this smaller, thinner vein would be a muscle running across the large vein, and the smaller vein, or the smaller diameter vessel would be on top of it. So that would be the sternocleidomastoid running between these two veins, from the mastoid process down to the sternum. Now, if you look right here, over in this corner, here's the angle of the mandible. Here's the facial vein draining off of the face, okay? And you can't see the maxillary vein, but it would be draining, it's shadowed behind the mandible. So many times venous drainages are more atypical than not. In other words, you don't necessarily see from one individual to another venous tributaries flowing the same way. In an individual, they usually are flowing a little bit differently from one individual to another. So we don't call that an anomaly. If it's an anomaly that causes a problem with flow, the patient will experience that as some type of a disease-related entity. So these venous channels, typically you would want them to drain directly into the internal jugular, but they don't always do that. Sometimes they drain into the external jugular. Now, try these again. I'm gonna probably switch over to my other slide. I can't get this going. Okay, so see this venous channel here running behind the mandible? Behind the mandibular ramus? Okay? What would you call a vein that runs behind the mandible? How about retromandibular? Okay.
Yeah, because we get behind us.
So the retromandibular is actually going to receive drainage from the maxillary vein, supposed pterygoid venous plexus. Okay. Once again, forget how Netter draws it, because once again, it's an enlarged image. When you see these vessels, they're really, really tiny vessels. Okay. The pterygoid venous plexus, if it exists at all, the way he drew it. But the external jugular could then take that retromandibular flow, but also the internal jugular can take that retromandibular flow. Now, one of the things that many times happens right here is that the facial vein and the retromandibular vein join about here at the angle of the mandible and together drain into the internal jugular vein. So they call that a common facial vein because The retromandibular is draining the deep face, the facial vein is draining the superficial face. So if they come together, that's a common facial vein, okay, that is draining the face from deep and from superficial, okay? So this is the upper portion of the internal and external jugular veins. They have this incontinuous relationship with one another. It doesn't matter. It doesn't matter to the individual. What matters is that blood flows in the direction it needs to flow to get back into circulation. If it drains mostly external and then into the internal jugular vein, that's okay. If it drains directly into the internal jugular vein, that's okay. But these are some of the variations that you see with these two venous channels, the external and the internal. Okay, and then here, just to get you excited, here is the pterygoid venous plexus, okay? Somebody asked me how many cadavers have you dissected? Probably at least 1,000. Okay, that's over 48 years. Okay, so never saw that. Never saw that to that extent. But Netter created this image, and Netter was a premier illustrator of his time, and just about everybody since Netter tries to draw it the way Netter did. Okay? Now, they should have told the bodies that, because I've seen it, minuscule little venous channels in there, but I've never seen it like this. I've never seen it like this. But this is that pterygoid venous plexus and drains into coalescing into a maxillary vein, which drains into the retromandibular vein. And then here is more likely what you get up here, the facial vein, joining the retromandibular vein, and that vein going into the internal jugular vein is the common facial vein. And then we get to the end of all of this, and there's the first valve. So the clavicle has been cut over here, all the way across. Here is the internal jugular on the left. Here is the subclavian on the left. There's a valve there at the bottom of the internal jugular at the end of the subclavian. What do we call this? Brachiocephalic here, brachiocephalic here. Here's the subclavian draining into the internal jugular here and becoming the right brachiocephalic, okay? So that's the first place that there is a valve that's going to prevent backflow. First place we're going to see a valve that's going to prevent backflow. Okay? And that kind of makes sense because we don't want the blood to all of a sudden from the head go into your arm. Okay? That would cause a hypotensive event that you wouldn't feel very comfortable. From the same standpoint, we don't want the blood from the arm going back up into the internal jugular towards your head. Okay? So that's a good place. I'm seeing that now, in grandiose experience. They're doing at Fairmont Boulevard. If you live anywhere near Fairmont Boulevard or live on it, they are replacing all of the sewer lines. These large, and they're colored yellow, but they're not nerves. Okay, so they are these huge pipes that they're interconnecting, and they're driving them underground with this machine that basically slowly, inch by inch, runs the line underneath the ground until it gets to a point where they can interconnect it to another sewer line. So in some ways, the venous channels are like sewer lines, taking all of the waste products and metabolism back into circulation. And then once again, we have to concern ourselves with this relationship, that the intracranial venous channels have a relationship to extracranial venous channels. Okay? Especially with you guys, you gotta remember that you are dealing possibly with infections of basically very exacerbated bacterial populations. Okay? Particular skin lesions, we're talking about staph. But streptococcus is no easy easy bug to deal with, and also some of the prolonged bacteria associated with prolonged periodontal disease is also kind of nasty stuff, like Bacteroides or actinomyces or things like that. Okay, you don't want that in your blood, you definitely don't want it to go integrated. And sometimes it can. Okay, all right, let's take a break here. Let's take a break. Let's talk about the last part of the vascular system, and that is this reticular endothelial type apparatus called lymphatics, okay? So, arteries do what?
Maybe we should all go. I second that.
Okay, so arteries perfuse tissues with nutrients, okay? What do veins do?
Waste product?
Waste products, metabolism, back in circulation to be processed. Okay, what do lymphatics do?
Transport fat.
Fluid.
There's a lot of like osmolarity with the interstitial.
Are there things that don't get from the capillaries to the cells or from the cells to the capillaries?
Interstitial fluid.
And where do those things wind up? The extracellular space?
Oh,
Okay. We talked about this. Okay. So, lymphatic capillaries are like fingers sticking into the extracellular space. What's their role? What are they trying to do? Is that, once again, does everything get from the capillaries to the cells?
no,
Does everything get from the cells to the capillaries?
no.
What are typically the things that get left there?
Water?
Very good.
Yay.
Anything else?
That's all I got.
Proteins, like albumin? Okay, so what happens if those things stay in the extracellular space?
Edema?
Its osmolarity is all wrong.
Water.
So what happens? You wind up, basically, you wind up dehydrating into your own tissues, into the extracellular space. Because if the proteins are left there, that is a osmotically active solute that is going to draw the water into the extracellular space. And so the water is going to find it difficult to get back into circulation. So what you're going to do, if that happens, is you're going to dehydrate. Even though the water's there, it can't get back into circulation. So if you dehydrate, what happens? Why is water important?
It provides no use for all those biochemical reactions.
It does do that, okay?
Waste removal.
It does do that. And it flows inside these vessels, right? And so as a component of those vessels, what is it creating for you in the vascular bed? It's creating for you blood flow and blood pressure. Okay? You don't have fluid in your blood vessels, you have no blood pressure. So for example, if you had a massive hemorrhage, your blood pressure would drop drastically because of the loss not only of the blood, but in particular that portion of the blood called plasma, which is loaded with water. Okay? So you wind up with kidney failure, things like that. But what else are the lymphatics doing? They're trying to capture things, not only protein and water, and bring it back into circulation. Where do they bring it back into circulation? Where area specifically? Where do they bring it back into circulation?
Feeding fever?
Well, part of that, it's true. Vena cava joins what vessel? Subclavian vein, pretty much on the left side, although we know we have a right-sided lymphatic system as well, but that doesn't drain anything other than the head and neck. So that gets back into circulation, so we get water and protein back into circulation. But as a consequence of that, what happens to the lymphatics? What can be out there in the extracellular space that can do us harm?
Bacteria?
Bacteria, viruses, cancer cells, okay? Atypical cells, and plastic cells, okay? Just plastic cells. So what do we have associated with these lymphatic channels to try and protect the body from those things? Lymph nodes. Lymph nodes. And what do lymph nodes do? They react to anything atypical that gets brought back into circulation, in particular the circulation of the lymphatic channels. And they try and stop it before it gets into the system. Do they always win? No. And what's the entity that they create that tries to deal with these vectors? Like lymphocytes? No?
Yes.
What do you have tomorrow?
We're gonna study, you're so studying for that. Okay.
What's the difference between T cells and B cells?
The T cells tell B cells what to do. B cells release antibodies.
Okay. Where do the T cells come from?
Thymus.
Okay, is the thymus around forever?
No.
So the thymus, the T cells react to things that come into our body that it then creates some type of antibody to try and defend the body from this entity. Okay. If it never came in contact with it, the body may be vulnerable to new types of vectors, okay, or to different types of vectors. Okay, so we've got lymph nodes all through the body. We've got lymph nodes in the head now. Talked about those a little while ago. We have lymph nodes back here in the back of your scalp. They're called occipital nodes. We've got lymph nodes around your ear, posterior auricular. This is your auricle. Preauricular. This is in front of your auricle. Parotid nodes are incorporated into aspects of the parotid gland all the way along the parotid duct, where they sometimes are referred to as facial lymph nodes. Okay. Jugulodigastric. These are sometimes a very special, large lymph node that winds up at the point where the jugular, internal jugular, crosses the path of the digastric muscles. So there's a large, sometimes a large lymph node here where drainage of these more superior lymph nodes go. Okay. Then there's superficial cervical lymph nodes that lie along the borders of the sternocleidomastoid muscle. Okay. Once again, there's facial lymph nodes that go along the parotid duct. There's these solitary submental lymph nodes, and there are some mandibular lymph nodes that lie in relationship to the submandibular gland. And then there are deep cervical lymph nodes that lie really deep adjacent to the carotid sheath, deep to the sternocleidomastoid muscle. And then we have a thoracic duct on the left side between the internal jugular and the left subclavian vein, and we have a right lymphatic duct on the right side draining into the right brachiocephalic vein. Okay? So all of this gets back into circulation. Okay? So if the lymph nodes don't stop it, it's systemic, and could be serious and could cause the demise of the organism itself. Okay? Now, looking at all these names, I could probably give you 5 books that will call all of these nodes something else. Okay. What's important to you is that you can recognize as you are palpating in underneath the mandible, in the neck, that you can recognize if the lymph node is enlarged, and once again, as we were talking before, whether it is hard and fixed, or whether it is enlarged, movable, and tender. Okay. So, you did an exercise, didn't you do this? Was this part of knowing the patient? Doing that exam, doing the lymph node exam?
Yeah.
Okay. So, you know, when you want to feel these cervical lymph nodes, you kind of have the patient turn towards you and take your fingers and squeeze along the borders of the sternocleidomastoid and make sure you feel them. For these lymph nodes that are associated with the submandibular gland or submental lymph nodes, what you really should do is have a finger and push down on it, or even a mouth mirror, push down on the floor of the mouth from above. At the same time, you're feeling underneath their jaw. So make sure that you don't miss anything. So this is just one lymph node chart here. There are many. There's a guy who did a textbook on nothing but oral facial infections. His name Topazian. If you want to spend $120, you can buy that book. Okay, but these are these lymph node chains. There are submental, submandibular. There are parotid. There are facial. There are posterior auricular and pre-auricular nodes that are down here. Here's this large jugulodigastric node over here. Here along the sternocleidomastoid muscle are the superficial cervical lymph nodes on the borders, and deep to it are these deep cervical lymph nodes down in here, okay? So these nodes are there to be reactive to any kind of vector that gets in from the extracellular fluid into the flow of lymphatics. Lymphatics aren't really, I mean, what you see here, aren't really continuous vessels. There are continuous vessels that they will drain into. What is the primary vessel that everything below the head drains into? What is that? What's that vessel called? That all lymphatic drainage comes back to the lymphatic circulation and eventually into the systemic circulation. What's that vessel called? Thoracic duct. Okay. Yes, Brian?
I don't know if you ever could have a human genome, but how do you tell the difference between a lymph node and a nerve ganglia?
Oh,
They look, to me, they look similar a lot.
Yeah.
It's just a little knob.
okay. The ganglia are interconnected to nerves.
Oh, yeah.
So as you're pushing on them or as you see them, probably the best example of looking at them is in the abdomen around the celiac trunk and superior mesenteric trunk. Because if you feel around there, and you can go in there and do it again, or even though we're not in that section, you can feel these little bumps. And these are lymph nodes, okay? And those are ganglia, right? So what do we know about ganglia? What's happening there? What's in those ganglia? What's in those?
Neurosoma?
Okay, nerve cell bodies. But what's coming to the ganglia? Okay, what's coming to the ganglia? Let's talk about it autonomically. What's coming to an autonomic ganglia? What comes to the ganglia?
Preganglionic.
Preganglionic fiber. Where was that? Where's the cell body of that preganglionic fiber? CNS. Okay. Where's the postganglionic fiber going to from that cell body? The effector organ, the organ that it is involved in causing to function. Okay. Now we have other ganglia that are not autonomic. They're sensory, right? And those sensory ganglia are receiving what? From what? They're receiving a fiber called what? The peripheral process. And that peripheral process, at its beginning, is interconnected to what? A receptor. Receptor, a sensory receptor. Pain, touch, temperature, pressure, proprioception. Okay? And it's going to this cell that lies in a sensory ganglia. What type of cells are these described as? What is their basic type of sensory neuron? What is their basic type? It's called a pseudounipolar neuron. Okay? What does this neuron then send out to the central nervous system? What's that process called? To the central nervous system. Central process. Okay? So ganglia are aggregations of nerve cell bodies that are not in the central nervous system. From an autonomic perspective, they can have a relationship to the central nervous system because the preganglionic fibers come from the central nervous system, brain stem or spinal cord. Okay? And the sensory entities can have a relationship between the ganglia and the central nervous system from the periphery. Okay? A lymph node, typically, as we find them in the cadaver, are somewhat solitary, and they usually do not look like little gray shiny things. They look like little brown oval shaped objects sitting in some of these areas. They're not yellow, they're not green, okay, but they are enlarged. If we see any in the cadavers this coming week, I'll show them to you, okay? I've actually shown some of you as we've gone through some of the cadavers. But what is it? Why don't we see it? Why wouldn't we see it in a cadaver? What hasn't happened to that cadaver? Why wouldn't we see large lymph nodes in a cadaver? Because they never had an infection at the time of death or any type of cancer at the time of death. So the lymph node was not engaged or challenged. Yes,
Can
Don.
lymph nodes be like distended and then stay distended for a while?
Oh yeah, they could be huge. We had a
Yeah, but
cadaver in there up until I think 2 years ago, a young woman, I say young because she was under 50, okay, who had lymphoma. She had lymph nodes the size of walnuts. Okay? Not only down in her abdomen, where we first noticed them, but up in her neck. I've got an image of that, I think, when we do the infections, the anatomy of pathways of infections. I think I still have an image of her, of those lymph nodes. You'll see the size of them.
What I mean is like if you have a big infection, then obviously there's gonna be a lot more cells in there and they're gonna get enlarged, but like.
Well, it's gonna produce a lot more cells.
Yeah, did it just like shrink like immediately after, or did it stay distended after?
As long as they haven't been damaged.
Okay.
As long as they haven't been damaged, they will reduce their size. Okay. Here is, over here, here's the thoracic duct, here is the common carotid, internal jugular vagus nerve. Here is, this is the left side, so the duct is coming up from the thorax and coming into this junction subclavian, internal jugular as it becomes brachiocephalic. On the right side, which they don't typically, they did not think there was a right lymphatic duct for over 200 years, until a group said this can't be right, and they started looking and they found a tiny thin duct only in the upper part of the body, only associated with the right side of the head and neck, that drained into the right brachiocephalic. Okay? Kind of interesting, okay? So the thoracic duct is taking this back into the systemic circulation. How is it doing that? It's draining into this venous channel, this brachiocephalic channel. Where do the brachiocephalics drain? They coalesce into what tube? What's that tube called?
What's the question?
What do the brachiocephalics come together to form? Superior vena cava. Where does that drain? The right atrium? Okay. And from the right atrium, where do they go? And from there, where do they go? And from there, where do they go? What is a major cause of death of older adults? Pneumonia. Bacterial infection causing basically an internal inflammatory process of the lung. Patients all the time will ask you questions that have nothing to do with dentistry. It will have to do with something going on with them from a physical perspective at that point in time, and they are concerned enough to try and ask somebody, what do you think? So you have to use your knowledge to think, and maybe get this patient somewhere other than your office where they need to belong at this point to deal with, or to at least discover what is wrong, okay? You're part of the gatekeeper system of healthcare. Patients see you more often than they see their physician. Okay. So you gotta be able to pick up on this stuff. You have to know your anatomy, your physiology, your pathology, you know, all of this stuff. You have to be able to ask the right questions. That's what we deal with in oral diagnosis. I mean, those of you that have been in there, like on a Friday afternoon when they're there, you'll see that I ask a lot more questions that are on that screen. Okay? I want to know who's sitting there and what's going on with them. That's your job. Okay, deep structures in depth. Let's look at some of these. Let's see if we can finish. Technology has really worked against me this afternoon. Okay, so let's look again at some of these muscles. There's these posterior muscle groups, these anterior muscle groups. These posterior muscle groups are primarily muscles that are helping to support the head at the cervical spine, okay? Allowing you to walk through your environment without having to just look at your toes, you know, and try and get around. Allow you to hold your head up and walk through your environment and see what's in front of you. Those are called rectus spinae muscles, or those are anti-gravity muscles. What's gravity? It's this force that's on you all the time, okay? That's causing your head to fall forward. So anti-gravity muscles have to work in some ways constantly to hold your head up, okay? I see, you know, sometimes I see some of you, your head's kind of tilting down, going like this. That happens to me too when I'm in long lectures. Okay. All right, so here are these muscles, trapezius, splenius capitis, longissimus capitis, semispinalis capitis. Interesting little muscles called rectus capitis posterior major, posterior minor, obliquus capitis superior and inferior. And the anterior muscles, these scalene muscles we'll look at, longus capitis and longus coli. All right, so here's sternocleidomastoid. Back here, here's the trapezius muscle. Okay, this is a posterior muscle, but it overlaps with a couple of other posterior muscles, levator scapula and the splenius capitis up above it. Okay, these muscles here are scalene muscles, splenius medius, splenius anterior muscles. Okay, or more anterior muscle groups. Okay,
Is trapezius the cut muscle or like the long muscle? On
it's the muscle that's being held by this hook.
Oh, got you.
Okay. It's a muscle being held by this hook. So let's look at some of these anterior muscles a little bit deeper. So here we have, once again, sitting under sternocleidomastoid, which is cut up there and cut down there, is going to be what? What's going to be sitting underneath that?
Carotid sheath.
Okay. When you go into the lab now, what you should be trying to do is find reference points for yourself for structures that you're seeing in the neck. Okay? Is it under the sternocleidomastoid? Is it lateral to the sternocleidomastoid? Is it medial to the sternocleidomastoid? In particular in the neck, That will help you know what you're looking at. So here's the trapezius. Here, down here, there's the omohyoid crossing under sternocleidomastoid. So what's this triangle in here? What's this subtriangle in here called? Subclavian triangle, minor vascular triangle, okay? What's that vessel? What's that vessel? They're subclavian arteries and veins, okay? Over on the right side. Here, behind, we've got some muscles that are attached to the first rib. This muscle here, that's the anterior scalene. We've got this muscle here, this is the middle scalene, okay? And then running out between them, what we're gonna see is we're gonna see the brachial plexus, okay? The rami and the trunks of the brachial plexus are running between, okay?
Between them or behind them?
Did you have a question with that?
Behind them or between them? You said?
Between them.
Between them.
Okay, we'll see that again. All right, so if we go deeper on here and get down to the cervical spine, we will see these muscles. Okay, here's the scalenus anterior, okay, coming down. Here's the scalenus medius, scalenus posterior, which is a tough muscle to see at all, and the scalenus medius. Now, this anterior and medius attached to the first rib. Okay, now the ribs are coming down in kind of this circular or linear curvature, okay? So we've got them. Posterior attaches to the second rib, okay? What did we learn about them in heart and lung? What did we learn about the scalenes in heart and lung? Do they have anything to do with anything going on in the thorax?
They help to lift the thoracic base.
They help to lift the first and second rib. What does that do?
Create negative pressure.
It helps to create negative pressure. It helps to expand the thorax a little bit more. People who are respiratorily compromised are constantly lifting up, contracting these muscles to try and get a little bit more air, emphysemics in particular. What's the other problem with emphysemics? What's the shape of their chest? Okay, how did that happen?
Chronic overinflation of the thoracic cage.
And how did that happen? It happened because lung tissue started to become basically less elastic and interfered with recoil of the lungs, so that the chest wall artificially expanded. So even though they had this larger thorax, they couldn't do much with it from the standpoint of breathing. Okay. These muscles here, this one's coming down from, these are ribs, so from the thoracic vertebral column and coming up almost to the second and third cervical vertebrae. This is called the longus colli. And then we've got a continuation of that up to the front of the foramen magnum called the longus capitis. Okay? So these are muscles that can assist in what? They can assist in bending your neck forward. Okay? Bending your neck forward. Okay? Or possibly even resisting overextension of your neck by these muscles in the back. Okay? So longus capitis actually extends in front of the foramen magnum, okay, and attaches in front of the foramen magnum. And what's behind what's behind this? What would be lying behind that muscle? What structure? Besides the vertebrae? What would be lying inside this canal in the vertebrae? Spinal cord. Okay. Here we see a little bit of the rami and trunks of the brachial plexus coming out between scalenus anterior and scalenus medius, and once again over here on the right, the subclavian artery. All right, there's another triangle. We don't typically try and dissect for this. I had a TA, I had a dental student who graduated last year, who he was determined to dissect this triangle. Now, this is one of these images we're gonna see. These are Jolly Green Giant images, okay? You wouldn't see anything close to this size in a living or dying or dead human being, okay? You would see a 1 inch by 1 inch by 1 inch triangle. So over on your left, here's trapezius. And then here we have splenius capitis pulled back. Down underneath the splenius capitis, we have this muscle. This is semispinalis capitis. And then between them, running at an angle towards the back of the mastoid process, over here, we have the longissimus capitis. Remember I told you, in the front, we've got sternocleidomastoid attached to the mastoid process. In the back of the mastoid process, we have longissimus capitis. So it's like the head is being positioned forward and back, depending upon how it's being tilted and what support we need to be able to control what direction in particular, what we're looking at, what we're seeing in our environment as we're moving through our environment. Okay? So then we take all of this off, and here is the second cervical vertebrae. Over here, this is its spinous process, and then over here is the first cervical vertebrae transverse process. Okay? So we have this little triangle here with these basically 4 muscles. 3 of them are really the true borders. This one here, okay? This one here, this one here. One of them is outside the triangle, but is still considered part of the triangle, okay? So this is like obliquus capitis inferior, obliquus capitis superior, rectus capitis posterior minor, rectus capitis posterior major. Now, why did they spend all this time talking about this triangle? Because look at what's in the center of it. There's a nerve that comes out and innervates those muscles. Those muscles are innervated by a posterior rami of C1, which now, this is below the occipital bone, so it's called the suboccipital triangle. And so those muscles are all innervated by the posterior rami of C1. Now they say that, by urban legend, that there is no sensory nerves in this nerve, okay? So what's giving back the proprioceptive response? And that's what I've said to colleagues in the past. I said, if there's no proprioceptive response, how does the nervous system know what to do with the muscles? So they are both motor and sensory, primarily now motor, but also sensory aspect. But they're posterior rami. Okay, what's the vessel? What's that vessel in the middle? It's red, so it's arterial. What's that vessel in the middle called? Take a shot. What do you think? Okay? Okay, that's the vertebral artery coming out of the first cervical spinal transverse foramen and entering into the foramen magnum. When you get high cervical spinal injury, we not only run the risk of causing an injury to the brainstem or the upper spinal cord, we run the risk of causing a laceration of that vertebral artery, which is probably worse. I don't know if it's worse or better, because I don't know if a hemiplegic individual is better than one that's dead. Okay, because basically when you lose all of that blood supply to the brain, you're basically having a massive stroke. Okay, so high cervical spine injuries are just horrible things for whatever cause or whatever reason. All right, so we talked about some of this. Posterior rami of C1 goes in the suboccipital triangle, innervates these four little muscles of the suboccipital triangle. The triangle is only 1 inch by 1 inch by 1 inch, okay, if it's that long. Very small. That's why I say this is kind of a Jolly Green Giant's neck, okay? Then there's a greater occipital nerve that comes up. What does that overlap with? What nerve from the front of the scalp does it overlap with, the greater occipital? Come on, just yell it out.
I got nothing.
Yell it out. What's the worst that can happen?
Supratrochlear.
How about supraorbital? Supratrochlear only goes as far as the forehead. Supraorbital goes to the vertex of the scalp. And then there is one that runs right down the middle that's called the third occipital. Why do you think they call it the third occipital?
Third eye.
Third posterior rami and cervical spinal. Okay? All right, so now anterior nerve rami. The anterior nerve rami are roots, trunks of the brachial plexus. What also is coming off of similar trunks or similar rami is the phrenic nerve. And also we have the ansa cervicalis formation that has a relationship to these deep cervical spinal entities, okay? And then also in the deep neck, we have vagus nerve running through the carotid sheath. We have hypoglossal nerve up high, actually running across the upper portion of the carotid sheath. And you'll find it in the cadaver just below the posterior belly of the digastric. And then we'll have the spinal accessory crossing the posterior triangle. And then we'll have the sympathetic trunk. Where do you think the sympathetic trunk is in relationship to these structures? What do you think that is? Okay, the vagus nerve is inside the carotid sheath. The ansa cervicalis is on the outside of the carotid sheath. Where do you think you're going to find the sympathetic trunk? What kind of a ganglionic group is it? What do we say it is? What kind of a group of ganglion is it? It's paravertebral. What does that mean? Adjacent to the vertebral column. Is the vertebral column in front of or behind the carotid sheath? Behind. Deep to the carotid sheath. So the sympathetic trunk is deep to the carotid sheath. And so you need to understand that. I mean, because right there you found the ansa cervicalis formation, the vagus nerve, and the sympathetic trunk, just by knowing one is in the front of the sheath, one is in the sheath, and one is behind the sheath. Okay? All right. Very close.
When you say sympathetic trunk, does that have something to do with like the superior cervical ganglion?
Absolutely,
Okay, so are we gonna find that in this region too?
absolutely.
Okay,
Why do they call it the superior cervical ganglion?
because it's above the neck.
Because it's the highest ganglion of the sympathetic trunk. It's also probably the largest,
Okay.
okay? Probably the largest. And what is in that ganglion?
Nerve fibers,
There are fibers,
the soma.
nerve cell bodies,
Okay.
okay? Where did the preganglionic fibers come from to those cell
The
bodies?
CNS,
Okay, what part?
the brain or the spinal cord.
Is that the dorsal root or the ventral root?
If it's motor, it's ventral, it's anterior, right? Okay. So what is the sympathetic nervous system said to be anatomically from where to where? T1 to L2 or 3. So the preganglionic neuron is there. Okay? So which preganglionic neuron from which thoracic spinal sections wind up synapsing in the neuron cell bodies in the superior cervical ganglion? Okay, anywhere from T1 to T5. Okay. Okay. If you learn anatomy really well, you can actually help your patients. All right, so here we're looking, here's the ansa cervicalis formation. Once again, with the descendants, hypoglossy, there's the hypoglossal nerve actually crossing the path of the carotid sheath up high. Here's the ascendant cervicalis, and here's the loop. That's what ansa means, loop, cervical loop. And that looks exactly like that in the camera. Okay, let's look at the brachial plexus, and we'll pick up on the cervical spinal, cervical vertebral column. Okay, so here we have this area again. Okay, so this is the left side. So these vessels are subclavian. This is a venous vessel. This is an arterial vessel. And this arterial vessel is branching from what structure? The artery. Aorta. This is draining into brachiocephalic on the left side. So internal jugular, subclavian, thoracic duct coming in. Okay. This nerve is running parallel to the carotid, inside the carotid sheath. So what is it?
The vagus.
Okay. This nerve is running over the outer side of a scalene muscle called the scalenus anterior, coming from C3, 4, and 5. So what is it? Phrenic nerve. Okay. This is the anterior scalene. This is the middle scalene. Those rami that are running through it are from C5, C6, C7, C8, and T1. Those are the rami of the brachial plexus. A lot of authors describe them as roots. The problem I have with that is that by definition a root is only one entity. It's either motor or sensory. Rami are basically spinal nerves that are mixed. Okay? So C5 and C6 come together here and they form a trunk. C7 does not form a trunk, but it continues out towards the upper extremity. C8 and T1 come together and form a trunk, okay? So where C5 and C6 form a trunk, that's called the upper trunk, okay? Where C7 comes down, that's the middle trunk. Where C8 and T1 come together, that's the lower trunk, okay? What rami pretty much has innervation of your thumb? Up. C6. Okay, C6. So cervical spinal injuries in us, in dentists, typically happen around here, and one of the problems they cause is they cause an interruption in relationship to C6. So we have difficulty moving our thumb. Do you think that that would be a problem for you as a dentist?
Yes.
Okay. Not as a primate, not as a primate below us like a chimp or orangutan or gorilla, because we have opposable thumbs. They do not. That's why we have been able to grasp things, grasp tools, and use them as effectively as possible. Doesn't mean that chimps and gorillas and things like that can't do that very well. Actually, the difference is they have opposable toes. They have an opposable hallux, a big toe. So they can hold with their feet a branch while they're swinging through the air, you know. So these then form down here underneath the clavicle. They form what are called divisions, and then they come down here and the divisions form cords, and then the cords give off main branches. From our perspective in this course, because we'll talk about the whole brachial plexus in the next semester, wherever that may be, and in relationship to what they're doing in relationship to the upper extremity, okay? the cords in the main branches that will give rise to nerves such as the musculocutaneous, the median nerve, the ulnar nerve, the radial nerve, the axillary nerve. Okay? So this plexus of nerve. A plexus is when nerves come together from different primary locations and intertwine with one another. That's why the superficial cervical nerves and the deep cervical nerves are part of a cervical plexus. This is a brachial plexus. We'll talk maybe a little about the lumbosacral plexus in relationship to that when we talk about extremities. Okay. Here's a map. Here's a map of the brachial plexus. Okay, so we'll look at this again. All from our perspective right now, I want you to know the rami, C5 through T1, and the trunks, upper, middle, and lower trunk. These are things we can see readily in the deep map. Yes.
Is the trunk just where they come together? Or
Yes.
is there something else special
Yes.
about it?
So C5 and C6 come together and form a trunk, an upper trunk. C7 does not have any interrelationship with C6 or C8. So it basically comes down as a trunk from the rami. So C7 rami and C7 trunk are the same. Okay. It'll help form some divisions, but it does not have a definite trunk-like formation at that point. And C8 and T1 from a lower trunk. Okay, let's stop there. When I leave here, I'm gonna throw my